I'm so sorry, everybody, for the delay, but let me ask you to just find your seats and take a cup of tea or coffee and have some breakfast while we introduce you and have some opening remarks for our THIA conference today. So first of all, let me wish you a good morning and welcome you to the 4th Annual Texas Health Informatics Alliance Conference. We are really thrilled to have you here at the University of Texas at Arlington. Inspiring and insightful day. This year's theme, All In, the future is here, augmented intelligence in healthcare. If that isn't something that we're all really confronted with in these last couple of days. And we did this and planned this a year ago, so we're right on target. It really reflects on the commitments to exploring how the fusion of human expertise in advanced technology is transforming healthcare. Today, we'll hear from distinguished speakers engaged in a dynamic panel discussion and participate in poster sessions and interactive workshops. As we embark on this day together, we want to say that we want to share our insights and inspire each other, and really want to thank you for being here and joining us today. I would like to take a moment to thank the sponsors who helped make this day possible. Please visit them in the exhibit hall in the lobby whenever you have a chance. Now, we also have to have a couple of housekeeping activities so that everybody knows where and what needs to be done. So the first thing that I'd like to do is to share with you the disclosure slide, which you can see no individuals with the ability to control the content of this activity has any relevant financial relationships with eligible companies to disclose to you. These activities received no commercial support, so we are really ready to roll. Next, I want to share with you some of our learning and outcomes today. The participants, we hope, will report increased knowledge about the use of augmented intelligence in healthcare, as evidenced by 90% of the participants describing at least one expected change or enhancement in their professional practice based on information learned during this activity. So put your thinking caps on and see what you take home with you. The next, please, is to just share with you disclosure to the learners for this particular slide, which you can see on the screen. The University of Texas at Arlington College of Nursing and Health Innovation is accredited as a provider of nursing continuing professional development by the American Nursing Credential Centers Commission, ANCC, on accreditation. Furthermore, the University of Texas at Arlington College of Nursing and Health Innovation is a Healthcare Information and Management Systems Society approved education partner. So you'll be able to get credits in that regard as well. Contact hours are also something we'd like to just share with you. I won't go into the great detail, but as you can see, we have very, very fine people here at the university. I want to particularly tell you that Dr. Sharon Blackberry, from our Professional Development Director, can be contacted if you have any questions. Now, let me share one more thing that I think that you have found on your tables. This sheet gives you access to the agenda, also the abstract for the packets, and the conference information. So that should be on every one of your tables. Now we're going to get to the action. This is where we start. And indeed, we're going to do this in a lightning fashion. Now, first of all, I'm going to just take the prerogative, if I may, since we're just a wee bit late, to introduce all of our panelists, or our lightning speakers who are here right behind me and with me, all at one time, so that they can just hand the clicker to each other and move forward with the lightning blocks. So the first speaker we will hear from is Dr. Robert Turin, is an assistant professor in the Department of Emergency Medicine and the program director for Clinical Informatics Fellowship at UT Southwestern. Raise your hand. There we go. Secondly, Dr. Estefany Gardner-Grab is a member of the Clinical Informatics Center mentor in the Masters of Science in Health Informatics program and Informatics Management for the IMAGIN, Imagine Lab in the O'Donnell Brain Institute, also at Southwestern, UT Southwestern. Our third presenter, I hope you raised your hand when you did. Okay, next please. Our co-presenters are Dr. Mari Tietz, and is the Mari R. Pickard Endowed Professor at the UTA's College of Nursing and Health Innovation right here at Con High, and Laurie Hicks next to her is a member of the Center for Rural Health and Nursing at UTA. And then on the end of the row here, we have Dr. Jorge Mauro Rodriguez Fernandez, is an assistant professor and associate chief medical information officer at the University of Texas Medical Branch at Galveston. So we are in for a treat, and I herewith pass the baton to our first speaker. Thank you.
All right, good morning. My name is Rob Turr. I'm an emergency doc at UT Southwestern in Parkland, and I'm excited to chat with you today about the results of an audit log analysis of patient portal use among Spanish speakers here in North Texas. This work was funded by the Texas Health Resources Clinical Scholars Program, and I do need to make a shout out for my co-PA, Robin Higashi, the qualitative counterpart to the work that we're doing here. We had a great team from Parkland, THR, and UT Southwestern that contributed data here, and it was a remarkably collaborative group to get parallel data across these sites, so thanks to everybody who contributed. The beauty of speaking to a giant room of Texans is that this problem is self-evident. Roughly 15% of the Dallas population is, for lack of a better classification, exclusively Spanish-speaking. And yet, current patient portal patterns among Spanish speakers is poorly understood. So our objective was to characterize and compare Epic MyChart use patterns between Spanish and English-speaking patients at Parkland Health, Texas Health Resources, and UT Southwestern. This is a quantitative mixed method study that used Epic Clarity data from all three sites using parallelly defined and mapped queries. And we included adult patients with at least one face-to-face or telehealth clinical encounter in the year following the 21st Century Cures Act information blocking rule passage. We were interested in the proportion of patients who were activated at baseline on the portal, who enrolled in the next year if they were not enrolled at baseline, and how much patients used the portal. So we looked at logging in, reviewing results, reviewing notes, and how often they sent secure messages. We tried to adjust for confounders including age, site, sex, comorbidity count, and the number of encounters. And we provide core descriptive statistics as well as using multivariate modeling to allow us to adjust for those confounders. There were in total 1.5 million patients included in the year that we studied. Roughly 8% of all of the patients were Spanish-speaking, with similar rates of female patients versus male patients, and a far lower rate of commercial insurance. Similarly, there's almost half the rate of patient portal accounts at baseline. After adjusting for confounders, we found that Spanish speakers were far less likely to have an account at baseline or to activate an account in the subsequent year. And among those who did have an account, patients were far less likely to use MyChart at all. This is particularly true for logins, where the odds of logging in were about a third of what they would have been for English-speaking patients. There were substantially lower rates of reviewing results at all, sending messages at all. There wasn't a statistically significant difference as it relates to reviewing notes, which probably has to do with the fact that very few people review notes in the modern era. Among patients who did log in, Spanish speakers logged in less. Among patients who did review results, Spanish speakers actually viewed more results, which is an interesting thing to discuss. Spanish speakers viewed fewer notes and sent far fewer messages. So, in summary, Spanish speakers were less likely to have, get, or use the MyChart patient portal compared to English speakers at 3 large health systems in North Texas. And those who do use it less. There are a wide range of interpersonal, technical, and socio-technical strategies that we can use to improve awareness, access, and usability. If you're interested in understanding why some of these findings exist, I recommend you check out our poster that'll be presented by Emily Rapaski, our project coordinator, later today at the poster session. And so if anyone wants to chat, you know where to find me. I will pass it over to Dr. Garduna-Rupp.
Can you see it? Oh. Well, hello everyone. I'm very excited to be here today at the THIA 2024. And without further ado, let's get started. Okay, so what is IDA? I'm gonna be discussing with you deep learning techniques for early diagnosis for patients at risk of IDA. So IDA anemia is affecting a third of the world's population, and iron deficiency happens to be the leading cause. It is associated to increased morbidity, increased mortality, increased hospital stay, and increased hospital readmission after surgery. Now, the problem with IDA is that it is not easy to diagnose. You can see this graphic here. Well, I'm not being able to point this, but you can see on the right a graph that represents the typical cycle of a patient with IDA. They enter non-anemic episodes, so they go anemic, non-anemic. So it is insidious, it is hard to catch. And you need at least these three components, hemoglobin, transferrin saturation, and ferritin at the same time, or at least at relatively close points in time. So as you can see, the diagnosis doesn't follow a linear trend. It is non-linear. So how could we build a model capable of recognizing IDA cases and controls 3 to 6 months before traditional diagnosis when you're having an insidious disease with non-linear data and a difficult diagnosis? So what we did is that we developed and evaluated 3 different deep learning models. So you are going to see them on the right: an artificial neural network, a gated recurrent unit network, and a long short-term memory network. So these are really good models when it comes to time series data analysis, when you have longitudinal data and retrospective data. And what we did is that we went to the chart and we gathered laboratory data from 30,000 patients. And we created sort of a data frame that we named the patient reel. And we did this for every single patient. And each reel had laboratory data about 52 groups of lab components from 2009 to 2020. And then we trained the models on these data. We split it in 5 folds. 3 folds were for training, 1 was for validation, and another one for testing, of course. And then we compared their performance. So in the table here, you see the summary of every single 100 epochs, every 150. And across all measurements, if you follow the red line, you'll see that the gated recurrent unit model outperformed all the others across all measurements: area under the curve, sensitivity, specificity, accuracy, with really good numbers: 0.89, 0.85, 0.75, 0.85 for these measurements. But now I want you to take into account that these predictions are coming 3 to 6 months before the diagnosis. So that's pretty good. Anemia hasn't happened, right? I just want to acknowledge everybody who worked in this project with me, especially my co-author, Jenny Won, that I saw her somewhere. So 2 years ago, she came here. She gave a talk about data curation and the possibility of creating a model for these. 2 years later, we have completed this project. It is a project that I just talked to you about and published it and successfully found a method for early detection of IDA 3 to 6 months before traditional diagnosis. So thank you, everyone, and I'm gonna let my colleague come and talk next.
Our title presentation is Ambient Large Language Models-Based EHR Documentation, Teaching Patient Safety. Presenters are Dr. Mary Tietz and myself. My name is Laurie, and we are both at UTA. We also acknowledge the other writers in this presentation. Next. All right, electronic health records have transformed patient data management, yet their complexity can hinder clinician efficiency and compromise patient care. Accurate EHR documentation is paramount for patient safety, as errors can result in misdiagnosis and improper treatment. Technologies such as ambient AI and large language models streamline data capture, enhancing documentation precision and reducing clinician workload. Next. Informatics in healthcare leverages information technology to collect, manage, and analyze health data, enhancing patient care and operational efficiency. Nurses play a crucial role by mastering healthcare technologies like EHRs, telehealth, and data analytics, improving patient outcomes. Proficiency in data management, patients, privacy, and technology integration is key. Next.
So taking off on that, the nursing practice essentials can actually be demonstrated in the following slides as well. One of the areas is ChatGPT, and in ChatGPT, the medical notes were actually collected through ChatGPT and ended up providing very accurate information and actually increased user satisfaction of those that were using the medical notes. So there was a good plus there and part of practice relating to information technology. Oh, okay, going back, sorry, going forward, yeah. Okay, there we go. And we're back to, okay. So the teaching is the other part of what we can do with information technology and can evaluate nursing faculty. And this one study indicated that there's a low level of information literacy relating to the faculty. And if you have that, then it's going to be difficult for that to be taught relating to the innovative technology. So the idea there is to provide faculty with give direct examples that they can that go with their curricular maps, curricular content, so that they can actually have standardized instructions whenever they're learning about the innovative technology, and it's also to get librarians involved whenever they to help with the information technology associated with the teaching. In another study about the power of large language models, that's also where it can be clinically useful for nurses to use. And in that case, they actually can optimize the EHR and actually save some time for documentation. The points about that in the NOM study is that they really wanted to be sure that the following factors. Data privacy, because you're moving a lot of data and you come from different areas. You want to be sure you've got data privacy. You want to be sure that you've got clinical accuracy in the information that's being looked at and being used by the clinician. And you also want to be sure that you have gaining acceptance of them. The other thing about it is the design. The design can actually be helpful, and the focus on this particular study had to do with the increasing integration into the EHR and having good workflow and training. In teaching patient safety and quality, you can actually use the advanced technologies to show the impact of data-driven clinical decision support. In terms of the challenges that you might have relating to using large language models and ambient health data, you want to be sure that you are avoiding the bias that's potential in that kind of data, that you are also having the clinician know that they still have autonomy in the practice that they're utilizing there, and not that they have to follow exactly what's in what they're seeing, and that you also are able to move through considerations of that. So for future directions, you want to be sure that you have teaching that is solid, that is tied to the actual objectives of the curriculum in both hospitals and academic environments. And then finally, the call to action there is to be continually learning, because this is an evolving process. Thank you.
Well, good morning all. I'm Jorge. Nice meeting you. So I'm going to be chatting just as a good segue for Mary to chat about Gen AI and some of the applications that we're seeing in the clinical setting, more or less our experience at UTMB. So no disclosures from my side. Just as an overview, we're going to go to the draft reply in-basket technology that we have deployed at UTMB, ambient documentation, which is pretty much what was, Mary referring, having our phone, then starting a clinic visit, and then as we're starting the visit, we're to be typing on the computer like maniacs, where we will be facing our patients. So certainly nice technology. And in the other side, AI has been here for quite a while. So we're going to go into rule-based logic and go into the some of the old AI that you can use and deploy into your EHRs. And then we're going to go and review the promises and challenges. Death by a patient portal. So probably you have seen this article. It really touches, even after COVID, we were seeing an explosion of messages. You can see the purple line. Well, it's supposed to be purple, I think it is. You can see how the in-basket messages really spiked up. The dashed red line is COVID, and you can see the number of encounters how it went up. That's the vaccination trend and so on. So at UTMB, we have 50,000 messages coming to our system, consistently. Then with COVID, we went to a new baseline, 60,000, and it is staying there. Did it change the actual workflows, the administrative time for our providers? It did not. So it comes to Gen AI, to kind of the lower level, the administrative tasks that we come into to have, into our repertoire. How can we deploy these tools to help us have more time and eventually not have a death by the patient portal, but rather enjoy? Be with your family, have some time to yourself, take your cat for a walk, your cat, maybe, your dog for a walk, and so on. Maybe you might do, take your cat for a walk. Then this is an example. This from Epic, you get an inquiry, then it goes to the GPT model, a cloud environment in which then is being processed by GPT, has been going to the different models. Now the latest one is 4.0, which came last week. So all these, you can see the replies coming there. Then the provider is seeing the messages and then is taking an action from there. Do I want to start with that reply? It looks fair enough. The issues that we might see is that it's lacking really the context. The patient had been seeing in clinic not that long ago. new medications, new recommendations in the last clinic note. So it provides some advice, but so-so. That's what we're seeing in terms of utilization. So we went, some of us, to UGM, and it's really striking. It's not like a silver bullet, which are like, oh, we're done. Now in basket, there's no more of an issue. 5 to 10% when it's being rolled out into the entire enterprise. Our experience into 2 focus clinics is around 20 to 30%, with some providers saying, like, I'm done. I pretty much set up my way. I respond messages my way. Thank you so much, but I prefer to just start my own way. So 20 to 30%. Nonetheless, there are providers that love it. I think probably some of the informatics team, like as we are, we just love and we get really engaged with these type of tools and so on. But some more providers are just going to set on their way and they're going to continue in their own workflows. So 20 to 30%, more or less just to stay on that, and there's some more metrics. In terms of the response certainly might be quicker, because now instead of reading an entire draft, now you can start with something, and it really decreases the burnout in terms of how you can respond to a patient inquiry. Next is ambient documentation. Again, the technology, you might put your phone over here and then rather face and talk to your patients. This is a slide that I shared, I think, last year. So again, this is a JAMA article that showed, like, this is a pediatrician, this is a patient that actually drew the entire clinic visit. The person who's facing the computer, well, you might know who that is, so it's the provider. So we're just being perceived as the typist, like, the administrative clerk that's now, like, instead of looking and engaging to our patients, now we're placing, like, orders and notes and so on. So DAX is the technology that we use coming from Microsoft, and it really allows us to, step next to, build again that relationship. Some of that's why we came into medicine, to build our relationship to help our patients. There are a lot of articles. There are probably 1 or 2 more as you look into. There is a reduction of burnout scores, increase, in the overall burnout perception. Take into account some of those articles took the old or like the most initial ones phases of ambient dictation. It's called DAX Express, which is why you can see words in the pajama time, the last quote. So read that literature with some caveats there, taking into account that this technology keeps improving. And that's something that we're saying is still, we need to have some help in terms of adding orders, diagnosis, and so on, but it's great to establish, great patient relationship, which has been seen with increased patient experience. Just the last one, rule-based logic, something that you can use and deploy into your own EHR old AI. This is not Gen AI, but it uses the basics. If I have a patient with shock, anemia, you may actually have those rules then being deployed, and then the patient may have to, the provider will have to select the appropriate logic, and then it will help us in our pilot. We have been improving our BCN metrics and so on. The promises and the perils you can see and you can imagine. So ambient AI, I think, is a great success. I see it like patient-oriented tool that will help us to increase or improve our relationship to enterprise. Hopefully, once we have more insights, which is coming, as we know, that will help us to probably enhance utilization. But as for now, just my opinion, probably is not there yet. For the ones that love it, I think we really enjoy it. Rule documentation, it's a great way to have really core documentation based on rules, the very basic of AI as back in the days. So I think we'll start with questions, and if you want to connect, please feel free to scan the code. Thank you.
Well, you certainly did it in a lightning speed, and everybody on time. This is really great. We have maybe time for one question, and I would also like to ask each of you, please engage with our lightning speakers if you have a question. So anybody have one burning question before we get us back on schedule and look forward to our keynote? I don't see any. Oh, yeah, I do see a hand in the back. Can you speak nice and loud?
We know that care partners are very, very, very involved when it comes to portal use, especially in the Spanish-speaking population, probably for mostly linguistic reasons. And so I think your theory is really, really interesting. You can definitely get into very granular audit log data about who was looking when. It would be, I think, tricky to get to it at that level of aggregation, but I think it's a really interesting thing to explore qualitatively, as well as sort of why we think they may be reviewing it more if there's sort of less access to the information from primary sources, and this is an attempt to get that information, or if maybe it's just a more engaged group. So I think, honestly, the best way to answer all of this is going to be qualitative.
Thank you so much, everyone. We'll exit the stage and look forward to the next go-round. Thank you.
All right, good morning, everyone, and let me offer my welcome this morning. I am Susan Fenton, and I am from UT Health at Houston, and it is my distinct pleasure to introduce Dr. David Jaffrey this morning. He is a global pioneer in medical physics and image-guided radiation therapy. As the inaugural Chief Technology and Digital Officer at MD Anderson, he leverages over 2 decades of expertise to enhance data integration and security while bridging the vital fields of biomedical engineering and medical physics. With 47 patents and over 300 peer-reviewed publications, Dr. Jaffrey's transformative work addresses critical challenges in cancer science and technology. And I have heard him speak before, and I think we're in for a treat. So without further ado, Dr. Jaffrey.
Slightly different one. Okay, fantastic. Thank you for the introduction. Really exciting work in the lightning round, and it was really lightning as well. Very exciting. I like lightning. David Jaffrey, I'm delighted to be here and talk with you about the way we're thinking about how technology is transforming healthcare, in particular, transforming the mission that we have at MD Anderson to make cancer history. You just heard in the lightning rounds, there is so much opportunity, and we are at the absolute beginning of technology really integrating into healthcare. This one. Okay. So the paradigm that we're advancing at MD Anderson is really to focus on not just the impact on the individual patient, but making sure we can reach maximally to impacting as many individuals as possible. This is thinking about our basic science for a discovery, potentially for a vaccine, for example, or thinking about how we work globally in terms of bringing new approaches across the planet to address the burden of cancer. Critically, one of the dimensions that we realized to move to this upper right corner as part of our strategy is to bring new technologies to the problem. It's very clear. Next slide. That's what happens when you're a Chief Technology and Digital Officer. You don't mind rearranging things on occasion. So it's very clear that the future contains very rich technologies that we could all bring to the benefit of the healthcare system. That's why a lot of you are in the room. And you see it from every dimension. It's not just being a technologist who's developed something, but it's a nurse that realizes that what am I doing here every day when I could use this? This is an idea I have. How do we engage everybody in the opportunity to innovate within the healthcare sector to impact the various things we have in our mission? And we see rich opportunities, avatars and AI, and I'm not going to use the word large language models again in the rest of my talk because it's a very popular term right now. But this changing the way we work is what we're talking about. The technology is around us. We're like swimming in it, like a little kid that gets thrown into a pool. So we always have to think about the opportunities. So what I did when I arrived at MD Anderson is we had a great IT team, and we still have a great IT team. But I realized that that team is not really the structure we need to move forward. It's really about innovation. It's really about using data to drive that innovation, talking to people who have hard problems, and then bending the knee of technology to realize that opportunity. So in the past 5 years, we've completely restructured how our team operates, away from being an IT team to a team that focuses on technology, data, and innovation. We provide strategic guidance to the organization. We're constantly scanning the frontier, listening to, flash lightning talks about what's happening and what the possibility is, but then working closely with our teams to advance the mission. And so this is a team that I built over the past 5 years, and they're just fantastic. In the top left corner is Dan Schoenthal. He's our Chief Innovation Officer, constantly surveying the frontier. Data is everything now. They say data is the new oil. Data is way more interesting than oil. And Caroline Chung is our Chief Data Analytics Officer. We've actually realized that the devices that we have around us are all fully digital. Clinical engineering now works with us closely. All those devices, tens of thousands of them across the organization, devices that nurses are interacting, that surgeons are interacting with, generating data, storing data, potentially AI inside those, also have to be managed. So Rafia Sakib heads it up. Craig Owen is our Chief Information Officer, runs what I call digital operations and infrastructure. Les Stoltenberg heads up the security domain. I'll talk a bit more about that in detail and towards the end of my talk. And Dimas is a fantastic project manager that helps coordinate and interact these large projects moving forward. And I get to work with Michael to make this team address the mission of MD Anderson with our 27,000 employees completely focused on cancer. How do we make technology hum? And the approach we take is not about bringing technology to the table. That's what companies do. That's not what we do. We talk about engaging with the organization. We have 4 things that we need to get to before you get that check mark in the middle. In this Venn diagram, we got to think about the relevance of the opportunity. Large language. I said I wasn't going to say large language. Anyway, for example, is it really relevant to us? Is it going to solve a problem that we really have? Meet with the people who are using and tackling the problem to make sure we really understand it. Where's the value going to be realized? Is this beneficial just for IT, or is it beneficial to nurses, to physicians, to the finance team? Where is that value going to be realized? That's that conversation. And then the technology, is it ready? Is it aligned? There's a great technology we are deploying now called Secure Chat, part of Epic. We looked at it for a long time. We were not convinced it was ready. But then it got better. Other groups put input, it got better. And finally now we're adopting it, and it solves so many problems for us, it's fantastic. So that conversation around readiness of the technology and our readiness to adopt it, have we put the foundational elements in place? That is this challenge that we have and the approach that we take moving forward. What I'm going to do is kind of give you a few highlights from my team. So this is Dan Schoenthal, he's our Chief Innovation Officer. He's remarkably applied for an innovation guy, but when you listen to him talk, he can break down every barrier. He can open up everybody to tell their ideas. It's really fantastic. And he has a philosophy around what is innovation and the approach that we take at MD Anderson. And it's a little different to everybody. Everybody has a little bit of a difference. But what we found is this common framing is really reimagining ways to change something for the better. That's the approach that we really see, and that lets everybody come around the table. And literally, he runs these workshops with Post-its and people in breakout groups, and they brainstorm and they ideate. And then we bring in technology capabilities, and we talk about the opportunity. Dan's most interactive team in the organization is in the operations space, like clinical operations, and the most active professional engagement by far is with nursing. They are one of the heaviest carriers of the use of technology in the cancer center. And you want to have that creativity side. You don't want to just be idea, but you also want the transformation side. Otherwise, it's just like a sugar rush. You want to basically get a protein bar, at least, so you can get back on your bike so that things keep moving forward. You have that engagement. Because if you go to talk to people about excitement and ideas and you don't turn around and do anything with it, that got hype, which is a little risk on the large language. I wasn't going to say large language models anymore, I promise. So creativity is the ability to look past the obvious, to transcend traditional ways of seeing the world, to create something new. So engage people. They have ideas. Every brain can contribute, which is so exciting. And it has to be done through collaboration. One person's idea suggests to another person, and they share two hunches, and that idea matures. So we're constantly turning this over. It's not a command and control architecture. It is a vital, exciting environment. And transformation is the evolutionary journey from a concept to a tangible. And many times, in fact, we explored some of these ambient technologies very early. We stopped. It was not ready. Our clinician said, it takes me more time to edit that thing than I can just do it myself. Now it's new technology comes back again. Those things that I never talk about now, they're coming back again and they're creating new opportunities. And we're reassessing. It wasn't a bad idea, it just wasn't ready. The time was not right. And so this drive from innovation to impact is the way we're now framing the way we take technology, the way we think and educate people across the entire organization. And this is, I'm going to go a little fast because I know we're a little bit behind time. You can think about it as Lego. Has anybody in the room ever played with Lego? Yes, do you still wish you could play with Lego? You know you still can. There's nothing stopping you. You can throw it in the dishwasher. It's all clean again, it works pretty well. But basically thinking about how we stack these pieces up, building together. And it's a pattern that you need your organization to learn as an approach. It's a skill. Innovation as an execution is a skill that we have to build. And Dan does a lot of work to build this within the organization. A great example was the need for change in the context of the pandemic. And the innovation team was hugely critical for us in the pace with which we've adopted virtual approaches. Anderson was way behind on virtual approaches, and the pandemic gave us that opportunity. And the innovation team was critical in generating that dialogue between legal teams, working across borders, regulation changes. There were so many things shifting. The roles, the responsibilities, what's the right technology, how do we choose? They played a critical role. They created that ecosystem for challenging and questioning, to move things forward, to implement and to realize. And also realizing that some things fail. That's okay. That's how you learn. That's how you move forward. So it's a really powerful tool. And so we really wrapped this around how we manage technology and data in the organization. And it continues on. Future thinking, making the right choices. And in many ways, it's not just about, hey, I'm going to bring some startup in and work with them. We're learning more and more that how you use your platforms, how you make those platforms hum, is a huge opportunity for innovation. It doesn't have to be the startup that you pulled in, the first person to use it. It's that discipline of making your platforms work well, because they're there. You have huge sunk capital. How to make use of this? So one of the things we've been focusing on is platforms. My CIO, Craig, he's a great guy. We say, got to stop planting more trees, and we got to trim the ones we have. Okay, it's like a nice little, what kind of, that small tree, that Japanese tree that they talk about? Yes, exactly, that kind of beautiful thing, concentrating. So we're going to talk about platforms and digital experience. Platforms are incredibly powerful nowadays. You need to be thinking about what you choose from a platform. And platforms, you don't want too many of them. It creates a really bad experience for people. Having to jump from one platform, log in, yes or no, are they connected? Furthermore, it's a lot of work for IT to maintain those, and they cost a lot. And what we're learning is that technologies like artificial intelligence, the fertile soil for those to take off is in platforms, because platforms bring the context together that they don't have a clue about. Humans can engineer context in a heartbeat. They can walk in and change the conversation because they read the room. AI can't do that. AI needs context fed to it so that you can really make it work. And what platforms do, if you're using them fully, is they help you establish that context. So it's the fast path for these technologies to have impact. And that's why you'll see Epic with its huge list of anticipated impacts. We'll test them, we'll see if they work through the discipline, but those platforms become critically important and making sure they work well. And interestingly, they are the path for innovation in many ways. It's super exciting to see this combination, and it's also the place where the data comes together critically. So these pieces really are a really powerful component. When we think about our platforms, these are just some of our platforms across the organization we use. Try to keep it to a limited number, but they all connect across that ecosystem. And if we think about bringing in new ideas and new approaches, they connect again. So this architecture of the water park of slides and ladders that our staff have to work within. We're constantly thinking about how it's engineered. How do we evolve it and how do we shape it? One of the things we put a lot of work onto is if you're going to invest in a platform, let's make it work well, okay? The clinical experience is a huge part. So we have a dedicated team that focuses on experience on platforms. They work to shape, to measure, to adapt and improve the experience on platforms. And we specifically looked at Epic. We have a very interesting program that realized that there's a linkage between burnout and the digital experience. I'm not saying specifically Epic. There's a broad issue around the ability to execute and the frustration associated with digital systems. And so we focus on that really aggressively. And we have a process called Thrive. And we have teams of liaisons. We have officers who are EHR officers. They're there. They're aware of the capabilities. They champion and engage. And we have clinical leadership realizing the criticality. And then we run these things called Thrive workshops, where we bring teams together. Nursing actually just went through this recently. Tell us what's not working in this interface. Tell us what you want to achieve. And then we give a reflective period of time where we adjust and adapt. Maybe they just didn't know about a shortcut. That's easy fix. Maybe someone said, why did you design it this way when we're doing this all day long? 3 more clicks. We go back and redesign. So that constant refinement and tuning is so critical. And then we measure it through class surveys to see how well we're doing. And these are called sprints. They run pretty quickly. We work with different groups, 7 to 8 weeks on average. The latest one was to go through with nursing, but we've gone through it with clinicians in many different departments in the past. And each department, even though we're all cancer, in fact, need distinct Thrive efforts to make sure they work. I'm going to go a little quicker here, but the key thing, these are the scores from the class ARCH collaborative survey results, where we take teams. These are from back in 2018. The first assessment we did, we had a little thing called a pandemic in there, which got us a little distracted. I'm sure similarly for you. But the ability to drive up these scores through this kind of adjustment, this is a combination of educating and modifying the platforms, is a great example of the kinds of tools you can use to make those platforms work better and better. And remarkably, when it works really well, we now got to go back and think, if this is working well, what's the advantage of the AI now? That constant back and forth is going to be really interesting to watch. We do the same thing on our other platforms. Microsoft drives us crazy on occasion. Maybe Microsoft's in the room. Our teams really do try to improve that experience all the time because we spend a lot of time on that platform. Medical device management. This is this realization we had that every single device in the organization is digital, has data on it, is a cybersecurity risk, and probably needs to be patched. Uh-oh. Are your medical devices as robustly maintained and managed as all your IT devices? This was a big question that came up through an audit that we had several years ago. And we've now taken an integrated approach where we've actually built an entire ecosystem of all medical devices across the organization because that technology, which now can contain AI as well, needs to be coordinated. So we've now brought together a team that does that, making sure that we can patch them, we can detect them, we do know where they are they secure across the entire organization. So this has been some great work led by Rafi, and it really kind of breaks down the barriers because the medical devices now, when they're being procured and thought about, the team's already thinking about the data. They're already thinking about where they're going to go on the network. They're already thinking about the implications for the software platform. Versus, it's on the loading dock, it's getting installed, which has very much been the path in the past. So we really structured an approach where we looked at what the purpose of this was, what the issues were that were emerging as the technology of devices became more digital and had data. How do we conceptualize? How do we organize? Do we want to have all that under one control? So we created an institution-wide committee with 40 individuals on it. It's a big place. Nursing is there, procurement is there, cybersecurity is there, data is there. Really thinking through the issues and making sure we can cover them and clarifying roles and responsibilities. And this is actually part of good device management in healthcare. The idea that that conversation happens first before you procure to make sure you can manage it well and it's safe and robust. They call hospital beds are now basically PCs with mattresses is what people call them now. Everything in the organization is connected. There's Wi-Fi connecting within the organization. There's lots of interesting risks out there. And so that paradigm of thinking through that whole process of medical device management, this is a standard shown on the left-hand side, we've now kind of gone in and broken it out and said, now the TDI team can really help to make sure when a device comes in, it will connect, the data will flow. What data does this device make? What's the ontological alignment between its data model and what we store in Epic? Can we auto-generate parameters from that device rather than having a human enter things in? That ability to align and streamline and integrate is the future very much. And in fact, in the future, a medical device will arrive. It'll register on the network if we let it. We'll detect its MAC address. We'll understand who manufactured it. We know what kind of data it generates. We can confirm the version number. The data model and the platforms will auto-generate. This is what's happening in the future. This is why we need to bring teams together differently to assure we can really use this technology moving forward. Now, we don't just do it all in one group. We realized it's a federation paradigm. So we've created custodial groups because the diagnostic imaging folks, they know their technology really well. The radiation oncology, they know their technology. We're not going to talk to them. We're not going to tell them what to do, but we're going to give them a framework in which they can operate. And it's really nice when a device just shows up and it works right away and the data flows because we talked about it beforehand. And that pace of change of technology is only going to get faster. It's only going to get faster. So we actually have this committee. It actually generates a report that goes up to the president, makes sure all the reports are done. All of our cybersecurity issues are monitored on these devices. Vulnerabilities are patched, and if not, we isolate them with special technologies. The compliance in terms of making sure we know every device is robust. Some 47,000 medical devices amongst almost 250,000 devices across the institution on the network being monitored. And these groups now work independently, and it's a really great meeting because we actually now concentrate on other issues, what's happening next, versus the compliance issues that used to dominate the conversation. So these are little vignettes I'm taking you through. I'm going to go a little fast because I know we wanted to get back on time. This is an exciting area. Caroline Chung is our Chief Data and Analytics Officer. She's actually very active in SB 2060, big conversation going on in Austin now, of course, and I think a conversation later today on how do we design ourselves for the future of computationally enabled or data science enabled, or you could say AI enabled medicine. And one of the things we realized about 5 years ago when she first started in this effort was we need to get our data in a pile. It is very much across every organization that I've ever seen in my life so far. Traditional, I have a device and I have a database and I govern it. That has got to go away. And it is slowly going away. And we're on that journey to move from this initial state to this future state where you do have experts working with that data, representative, curating, engaging, but it's not bound by servers or databases. It is becoming a governance conversation. So Caroline's done a great job in building a complete data ecosystem. And she and I drafted an article around principles of how data needs to flow to enable AI to actually come to life, and published this back in 2021. The idea that, and this is probably familiar to the informatics community, that you need to keep the observations in context. That metadata around them is super cool, particularly critical for AI. If you have that, you can actually assess the quality. That's what happens in a curation process. You go and curate data, you look at other data elements around it, you're doing that. That could be automated as well. Knowing where it came from is critical, especially in the time now of fake generation of data. That provenance, knowing its origin for everything from a clinical decision-making through the FDA approval of a drug is very much a requirement moving forward. Having pools of data pulled on when you want of unknown origin is not the future. The structure of how we flow data to use these new technologies has to be completely rethought. And the cool thing is if you know where it came from, you can talk to the person that knows the most about it. That's that governance connection that binds individuals and actually connects to everybody in the entire organization. Not just someone in IT or someone in data, but actually everybody. We call this the first mile strategy for data quality instead of the last mile strategy of curation. So Caroline has built this incredible, completely new department called Data Impact and Governance. It has a completely different architecture around these principles and concepts. She's generated what's called data offices, where different organization components go to those offices to access and interact with data. It's actually streamlined the requests for data from around the organization. Our data teams within my portfolio used to get requests from all over the place. People from the same team sending independent requests for the same information, and we give it back, and they're asking for different mappings. That's super inefficient. So connecting that and streamlining that is a huge advantage for us moving forward. So I'm not going to go into detail, but just fantastic. And the tech stack that we use to support this in the back end is extensive. Happy to talk about it in more detail. We call that the context engine. And the context engine is an engine that allows us to keep the data in context. And if your data is in context, you get insights in context. And if you then know you can apply those insights in context, you'll get a better result. And this is an entire ecosystem where we have these data offices, people have questions, they can go to them. It's really a people, processes, and technology stack. We've got some great examples. I'm going to go really quickly where this is actually a clinical science question that was answered by our research data office around the role of KRAS mutations in pancreatic cancer. And it just is a very much more of a self-serve paradigm where people can go with a question, engage that research data office. They've heard similar questions before, they bring value to that question, and they can bring data forward for the individuals to answer their question. And it's on a common tool base. So tools and techniques they develop stay in the context engine so they can be reused by others. This really builds for us this paradigm we call a data science ecosystem. And one of the agendas we have within our strategy, which I didn't talk about deeply, and I'm not going to talk about too much, is that we have a desire to build data science into every part of the organization, into business, into operations, into care, into research, which is super exciting as AI keeps advancing. And it's not just a bolt-on to the organization, it's literally changing the entire internal core of how we manage data and technology to support this concept moving forward. So full alignment of our spend in this direction. Which leads us to a brief conversation on AI, which I have only 3 slides. It's very clear that we are not really prepared to manage this technology in healthcare, let alone the rest of the planet. And there's a lot of people wringing their hands about how to do this, including the governments. There's over 100 bills that are in development right now across the United States, in states and federal levels, on how to govern AI. 100, over 100. This is a problem. And the idea is that it can be managed at that level without really realizing, as we all know, that it has to be managed at this level, in the clinics and hospitals across the country. This is the realization. It's not going to be done for us. We have to change ourselves to figure out how we can make use of this technology moving forward. And this is Caroline's work, and her team has been exploring, connecting with all these groups and hearing this dissonance between we're going to be responsible for its use, we need to figure out whether we can trust it. That's going to be on us, not the FDA, not some government agency. It's going to be on us. What I'm disappointed about is that people aren't talking about that, the need to rebuild ourselves to be able to have not just a department of human resources, but a department of robotic resources that need a lot more maintenance than the humans even do. So what is our ability to support that? And so Caroline and her team have been building an architecture for model lifecycle management, model being any kind of model, any kind of computation, any kind of prediction. That capacity, how do we steward it? How do we bring it along? Where does it come from? How do we decide to turn it on? How do we monitor it when it's running? How do we decide to turn it off? There's a concept called AI bullwhip, which is a really interesting concept promoted by a team that wrote a book called Power and Prediction. It's out of the University of Toronto. And they describe this example as if in a supply chain of avocados in restaurants and people is that if everybody starts to use AI at each step, and everybody starts to optimize their steps, the roll-up of that optimization could put huge pressure on the supply chain. Because their demand from day to day is not the same as the variability in production of avocados in the field. So this will produce a period of time where we're implementing these technologies and there's going to be a jostling and uncertainty in how they impact. The great example was we have an NLP pipeline that we use in the context engine, been using it for almost a decade, maturing very well. And they said, let's do auto-generating notes. I said, wait a second, okay. Our NLP pipeline is calibrated off the practice of our physicians for the past 10 years. If you insert an AI-generated version of those notes, you destabilize our NLP pipeline and all the downstream effects of the use of that pipeline. So thinking through the implications of deploying a technology in a system is really critical. I won't go into detail. Reach out to Caroline if you're interested in this topic. It's super interesting. I'm literally building the teams to manage these technologies. Oh, one other thing is we realize data science is really important, so we have this initiative to launch an institute, which I'm very fortunate to lead with Caroline, and it's a lot of fun, and it really drives educational elements, building skills in data science across the entire organization. I'm just going to touch on it briefly because we're short for time. And my last topic, I'm trying to get us, we're okay for time? We're doing for time? Oh, that's even better. Of course, this technology period is super exciting. We're going to have more and more of it. But the technologies we have today were not built for a state of continuous attack. Just not built for it. Like email, the way we interact, SMS, texting, just not built for it. Just this reality of it. I mean, we said digital tools, really cool. Let's go, let's go, let's go. But no one really thought that anybody would want to attack what we were doing. So there's a period of time where we're going to have to deal with the fact that these systems are vulnerable and shore up in substantially awareness and support for it. That's the cybersecurity challenge. In fact, I argue that cancer is the most digitally dependent form of healthcare in all of medicine, and the dependencies we have on it are extreme. When we bring a patient in for radiotherapy, for example, we commit to treat them for 6 or 8 weeks. And once they start in that path, you can't restart. It's started. So interrupting that path substantially interferes with their likelihood of outcome. So we cannot have an interruption of the almost 1,000 patients we have under treatment in radiotherapy, for example. And we cannot deliver that care. It's impossible. Those robots that deliver the radiation cannot be reprogrammed in a few minutes or even in a day. So we have a big focus on cybersecurity. In fact, it's one of our highest risks in our enterprise risk matrix within the organization. We have 850 new patients arriving every week to see us now. We're almost over 900 now. 600 radiation oncology visits each and every day within the organization, 675 infusions, 75 surgeries, over 1,500 patients a day arriving with expectations that we know what's going to happen and they're going to be supported. And without digital systems, that just basically grinds to a halt. So it is one of our highest risk lists. It's got a very high velocity that changes from day to day, and we realize that things like Change Health and the insurance and coverage mechanisms, the external dependencies are so critical for us as well. So constantly understanding what the dependence we have for our care is an active conversation. I'm sure many of you have lived through this recently. So what we decided to do is leverage something else that's going on in healthcare, which many of you may be aware of. I'm sure your organizations are. It's called the creation of a high reliability organization. How many people here have high reliability organization agendas on in their hospital? Please put up your hands. Okay. For those of you who may be in academia or students and not yet aware, this concept of high reliability organizations came from many different places where it's just not acceptable to fail. So how do we create the culture, the methods, the tools, the education so that we cannot fail? And this came from, for example, from the nuclear industry. It's not a good idea to have a failure in the nuclear industry. Any debates about that? Oh, very good. The airline industry, not a good place to have a failure. So this philosophy of having an organization that is extremely high in reliability allows us to do things that we could never have thought before. And we knew that healthcare was full of potential mistakes and mistakes that harm individuals each and every day. And there's an opportunity for us to make healthcare a high reliability organization. Many organizations now have adopted this, and there's lots of interesting tools and methods that have been pulled from nuclear, pulled from military, pulled from the airline to help us with this. So HROs operate under very trying conditions at the time and yet manage to have fewer than their fair share of accidents or mistakes. These are high reliability organizations. And you think about a patient, super vulnerable, coming in with an expectation we're going to help them. This is an example where we need to have HRO paradigms operating. So HRO, really operates to make systems ultra safe. And so what we did is we have an agenda of HRO, safety reviews, we learn from root cause analyses across the organization when something doesn't go right. We take those learnings in a no blame paradigm, we bring them back for change and opportunity. Feeds into the innovation agenda, by the way, pretty well. And we thought to ourselves, and we saw this article in parallel, which is super interesting, is that why don't we align the cybersecurity problem with high reliability organization? Because it is a method of failure that would have a huge impact across the organization. So what we've started to do at MD Anderson is to communicate on the channel of HRO. There's already a channel, like a sort of a TV channel of sorts, that's broadcasting and messaging high reliability organization across the end. We can just overload that, ride along the security message of cybersecurity. And that's reinforced by this great article, Stephen Weiser and a few others presented, talking about the similarities and parallels from a safety to a security conversation. Because ultimately, if the systems are not secure, they are not safe because we're under a constant attack, basically. So the first thing we did was to raise the awareness. A principle of high reliability organizations is a constant awareness of the potentials of risk and cognitive sensitivity, making sure that you know what's going on in your organization. So we created a dedicated cyber alert level that operates within the organization. Because the digital systems are so critical, we tell the organization, if everything's just fine, we've never been at low, which is really disappointing. We're usually at guarded. Sometimes we're at elevated. Occasionally we go to high. We go to high when one of our third-party dependent organizations or members of UT, University of Texas system, because we share a network with them somewhat, when they're under attack, we go too high. We start to turn things off in connectivities and change the way we interact. We've never been at severe. That's a good thing. That usually means we're under a confirmed attack, and the organization needs to know that, of course. So these kinds of opportunities educate and orient people. There's also some tricks in the high reliability organization, a thing called STAR. It's like you're about to, if you're a nurse, you've probably heard of this, you're about to inject something, stop, think, act, and review. The STAR methodology, super helpful when checking your email. Stop, think, who's this from? Do I recognize it? I do or I don't. If I do, I will act. Review, make sure nothing went sideways. Very similar opportunity to apply this to assure security within the organization. Super helpful, easy messages that stick with every one of our 27,000 individuals in the organization. We also have a process as part of the HRO, which is called tiered readiness briefings. These happen every single day. Teams of leaders come across at every level in the organization, and they tell each other what problems they're having. It could be, we're out of contrast agent in diagnostic imaging. That could be one. Or someone hasn't cleaned up, or we're short-staffed because we have an outbreak of COVID in one of the areas where we didn't expect to lose staff today. Those all percolate up. What we then ask the teams to do is, if you see anything out of the ordinary with the digital systems, if you see anything that doesn't seem normal, promote it up through the TRB. Because that early sensing is so critical for our ability to respond and defend in the case of an attack within the organization. Now, phishing. How many people here have been through a phishing education program? Have you ever clicked the fake fish? Yes, nobody want to say you clicked it. It's very important to share the time that you clicked the fake fish with someone else, because that storytelling is really, really important for everybody to become aware and increase their sensitivity, because humans love stories. So we built a huge program. We run it 6 times a year. For all 27,000 of our employees are phished 6 times a year. And if you click twice within the 6 times, you get one message. If you click 3 times, you get a conversation with your manager. It's pretty serious. We take it very seriously. Because you could imagine, how could we explain to 20, for the thousands of patients that come through the door that someone clicked on something? That's a pretty difficult conversation. So we've been working on this, and it's been very interesting. Back in 2019, they would say high-performance institutions had click rates of under 6%. Now, these are our click rates. Not really formatted perfectly, but there's 2 pieces of information here. The graph on the left, the set of bars on the left, is the click rate, and the graph on the right is the reporting of fish by our teams, because they can click on a report button in the email and send in, and we say, good job. They like that. Nicely going up, but if you look at some of those click rates, you'd be going, wow, those are really big click rates, David. I wouldn't be showing this to anybody. We don't use regular bait, because of course the better the bait, the more likely it is to get people to click, okay? But this is what we do. We watch to see what's happening in the ecosystem outside. We know what time your tax documentation is going to come out. And so does the cyber criminal. They know what time to talk. So we put things out there. We custom shape the fish. We get an email from our CIO sent to you. Congratulations, rewards. That was one of the peaks we had a while ago. Because that's the reality of it. We want to basically inoculate the 27,000 people to the latest antigen that's in the ecosystem. And if we educate, they're sensitive, and we can stop that click. Of course, we have many other defenses, but there's always this gap, and it's getting more and more complex in the social engineering piece. So we were super excited when what we did last time was we went back to a very vanilla fish content that you can just basically get from the fishing companies. There are fishing companies. It's not Highliner or they're fishing companies now. It's generate bait. And we gave that bait to our teams in the last cycle, and 1%. They can get that standard bait really well. And it's part of the training, driving all the time to increase their sensitivity. So I'm super excited about our latest click rate, but it's going to go back up because we're going to move away from the vanilla bait. And that's just the reality of it. It's a constant exercising of exposure to these fish antigen to keep the immune system getting trained. Isn't it amazing? Okay, so the awareness, we give teams, we help our managers educate and orient. But this clicking it in, CRISPRing this into high reliability organization is just so natural. You don't have to make a huge effort. Just talk to your HRO champion about cybersecurity, and it just blossoms. It's a great example of using a platform. Okay, just a few key takeaways, and I think I got you back on track with time for maybe one question. The pace of technological change will never be this slow again, okay? This is true. I know, are we having fun yet? Exactly. Data-driven innovation is the critical and robust path for managing technology in healthcare. The shiny rock, there are a lot of shiny rocks out there right now. Just think through and take the time. If you're interested in the book on power and prediction, they talk about AI as a very exciting, just like electricity was very exciting in 1895. But it was well into the 50s by the time 25% of homes in the United States had power. Okay, it takes time. So it will help, it will come, but it takes time, and we don't want anybody getting electrocuted. So this process, I think, is really key. Requires a deep partnership. It's not an IT activity, it's not a technology. It is critically, these things are getting closer and closer to mimic what we do. You need to be the we in that conversation. You need to draw that together, which is super important. And healthcare organizations need to invest in new skills on data and model management. In fact, the DIR is now, of course, asked for a submission in Texas of all the algorithms. California has also done the same. If you're not generating an inventory of all your automated algorithms as an organization, you're in trouble right now from a state perspective. And what's your process to release them into the ecosystem, to monitor them, to shut them down, and to make sure the data feeding into them just like our NLP pipeline isn't shifting because of other changes in the organization. And the growing risks and benefits of digital dependence is particularly critical for cancer care, so the cybersecurity topics. And this will be this way until we make stronger and stronger platforms into the future. So with that, I'll stop and happy to take questions. Thank you very much. I went a little quick through some of those. If you want me to expand, I'd be happy to. Or you can just grab me at coffee after this.
Hello, my name is Natalia Ramirez, and I am a biology major at Texas A&M International University in Laredo, Texas. Something that really interested me is your portion about the clinical burnout, that your technology is supposed to assist people in recognizing some of these things. So I'm kind of curious if you also look into how often these people also experience clinical burnout, and if perhaps you also have it to see if maybe it is this one specific area, to see if maybe it's something internal. I just wanted to know if you had the technology or the means to do that, or if there's something in the works for that.
Yeah, we've got a big focus on the broader scope of wellness and burnout, sort of a symptom of a lack of attention to an ecosystem for wellness. The digital piece has always got a lot of pressure and press. I think at some level it's a little bit overstated in terms of certain specific technologies, which is interesting because you look at burnout in healthcare, it's across the board, no matter which vendors you're using and so on and so forth. There's lots of good evidence of that. And I do think, though, one of it is this overwhelming amount of information that clinicians are expected to somehow integrate. I mean, humans typically are pretty good at having 5 variables in any decision making. You're going to go buy a car. If you list beyond 5, you probably start to forget the first one you listed. Color, kind of car, maybe brand, leather interior. If you go too far, then you start to forget. So humans are good at taking about 5 variables into decision making. The number of variables available in healthcare is just in the thousands. It's incredibly stressful. So how do we help with that decision making process? The other thing that I hear a lot from our teams are, we don't want more yoga, okay? we want the systems to be smooth and not frustrating. That's what I hear. And so how do we take away that frustration step so that their decision to make something happen and their ability to make it happen is actually shorter and more productive? And that's where I think there's a huge opportunity to make sure the platforms are efficient and give feedback to the Epics and the Microsofts about what we need. And to me, that's that whole ecosystem. And of course, appreciation for what people do. And one of the things we benefit from at Anderson is we have a very clear mission. People really lean into it and they really see the impact of their work. So all that, I think, comes together to make an ecosystem where burnout can be reduced. I hope that helps.
Thank
you have another question. It looks like you have another question.
I do have a follow-up question, right?
Yeah.
So as you know, as a field as demanding as healthcare, one of the biggest or most precious things about it is time. And so I'm wondering if with the implementation of these platforms, is time being taken into consideration to ensure that these people are being able to input the information accurately with the amount of time that they have, or the little amount of time that they have? Because as you know, if you're in a rush, you probably aren't going to answer as accurately as you would like.
I think this is key, and this is where this sort of, thank you for raising this, is this frontline or first mile strategy around how we think about getting information into the systems. And one of the things we've done is launched with a program called a data literacy program, and that helps people understand the implications of what data they're putting into the system. And you could say that's going to make more work for them because they're thinking harder about it, but at the same time, we should be thinking about how we can bring tools to the table that can auto-capture some of these things. That's why I think the ambient listening is super interesting, because the ability to really capture more information in that context is really interesting, which should serve to reduce, and people can concentrate more on the interaction with the individual versus the keyboard.
Thank you.
You're welcome. Super interesting question. Okay. No further questions. Almost back on track. Oh, one more question.
Yes, hi, my name is Kiara Monosano. I'm also a student at Texas A&M International University. I wanted to ask, how are you going to prioritize the implementation of such technologies and kind of prepare people to take on these technologies in more rural areas or maybe areas where they're not as technologically advanced, or especially in underserved medical communities?
Yeah, this is a huge point. Thanks for bringing that up. We have to do a lot of education and training in the organization as well, specifically around cancer and cancer nursing and the like. And I do think this is a challenge. I don't think we have the answer to that, honestly. I think these technologies are going to heighten the sort of digital divide between different organizations. And this is where I think that being aware, if you look at Biden's executive order on AI, it was a lot about industry, a lot about regulation, but not so much about what's happening at the provider level, to think about how we can adopt and support. So we've called it out several times, and that we need the resources put in place to allow this to be available equitably and not to just marginalize out people who are already marginalized because of their lack of maturity in the digital domain. So it is a big topic, and I think hopefully we get talked about more today, so thanks for raising it.
And just a follow-up question, how will you incentivize the implementation of these programs if it is, more expensive or there's more technology required to implement, AI and machine learning?
I mean, there's a great phrase, there's no free lunch. And so if you're going to get the benefits of the technology, you're going to have to invest a little bit. And I think and making sure that investment can happen. That's the message we're sending internally. It looks like this is great. It's going to solve everybody's problems. Okay. If you want it to really solve problems, you need to get the foundational pieces in place and build on that. That's what I think is critical.
Alrighty, thank you.
You're welcome.
All right. Dr. Jaffrey, I'm back here.
Yep. Hey.
Thank you so very much. Let's give him another round of applause. Okay, I think we're gonna move on. Dr. Jaffrey, when do you have to leave today?
Not till sort of mid-afternoon.
All right, so if you have questions, and if you didn't want to stand up and ask it in public, go find him.
Please do, please do.
All right.
Thanks for the invite, you guys.
Okay. Where's Dr. Lee?
Thank you so much. Thank you. Hello, everyone. We've been already sitting for about 2 hours. Why don't we have a stand up? And because for the blood circulation, and then stand up, please, and then stretch yourself for 1 or 2 minutes, okay? Yeah, stretch way out. Yeah. Stand up, because we will have another 1 hour session. So then we really need your fresh brain with oxygen on your brain, okay? All right, but don't go out. We just stretch, okay? Don't go out. All right, so then have a seat together. So we will start in a minute. Yes. Yeah. Okay, please. Yeah, sit down. Yeah. Right, yes. Yeah, this is, I'm Mi Kyung Lee. I'm professor and in the doctoral endowed chair for informatics and healthcare transformation at Texas Women's University. It's great, my great honor to introduce today's speaker, Nora Cox. Nora Cox, let me introduce her, okay? Nora Cox is a leading healthcare advocate in Texas, known for her pivotal role in shaping health policy during her 5 years at the Texas Capitol. During that time, she represented then the Governor Rick Perry and led significant Medicaid reforms. As the Chief Executive Officer of the Texas eHealth Alliance, The Nora has been instrumental in modernizing the healthcare delivery. She founded the Alliance to strengthen the voice of health IT stakeholders and successfully advocated for legislation that expanded telemedicine and telehealth services across the state. So with a degree in government from the UT Austin, Nora is highly sought after speaker and consultant, and respected for her expertise in health information technology and policy. So today, Nora will focus on AI registration in Texas, focusing on recent legislative activities, development and debates that are shaping the future of AI in healthcare. With important sessions coming up 2025, this is a critical presentation for all of us, looking to stay informed and proactive about Texas healthcare laws. So following her talk, we will have some more interactive Q&A sessions. Please join me in giving the Nora Cox with a warm welcome, the big round of applause.
All right. Good morning, because we're still in the morning, so good morning, everybody. I want to thank Dr. Jeffrey for that amazing presentation. I don't know if he's still there. We did not collude, correct? You and I did not talk. He could not have set me up more beautifully to talk about the legislature to all of you and their approach to artificial intelligence. So before I even get into the slides, I want to say this. The Texas legislature is not a high reliability organization. So I'm just going to ask you to keep that in mind as I'm talking, because they're not. They would fail every single one of our colleagues' standards. When Dr. Susan Fenton invited me to do this, I thought I would have draft legislation to talk to you about. And I was really excited. But shockingly, the legislature didn't hit one of its deadlines that we were expecting to see a draft. So you're going to have to bear with me as I try to lay this out and then tell you what to look for and what you can possibly do as this topic is in motion. So just to start a little bit more about me, I'm a nerd. Let me be really clear. I grew up in Plano. My family's from Fort Worth. And for my UT Arlington folks, my father attended Arlington State College in 1958 and was an NCAA junior college track and field champion for Arlington State College. So I could not be more delighted to be here today. Is that not amazing? Also, if that didn't give my age away, I am rocking a vintage 1989 jacket with shoulder pads because I am Gen X and I make no apologies. I also learned to program on a Trash 80. In fact, that picture to the side is me getting a trophy for making a ball bounce around on a screen faster than any of the boys in my middle school. That picture on the other side is a Commodore PET 2000 ran on tape drives. That was my family's first computer because my father was a fiber optic design engineer for Rockwell International, which is now Alcatel-Lucent in Richardson, Texas. My mother has a law degree from a university in Athens, Greece, so I was basically bred in a lab to do this thing that I do. A little bit about my organization, because this is my disclaimer slide. The Texas eHealth Alliance, we are a 501c6 nonprofit. We are a trade association. I cannot discuss specific companies or products or technologies. The Federal Trade Commission does not like that. What that does allow me to do is bring organizations, institutions, vendors, all sorts of folks into my tent to talk about public policy. And real quick, where are my Texas A&M, TAMU I students? Where are my Laredo students? I could not be happier to see you all here. New jokes today, okay? Because you heard the old jokes last time, so today you're gonna get new jokes, I promise. Here's what we're gonna do. I'm gonna talk a little bit about the timeline because the timeline is important when you're talking about the legislature. I'm gonna talk about what they've been doing, and you're gonna see these slides and you're gonna think to yourself, oh, for the love of all that's holy, she's not gonna read that whole slide, right? No. I actually think there should be a law against people reading their PowerPoints word for word. I don't think you should be allowed to do that. What I am gonna do is walk you through what the legislature has been doing, and you're gonna notice the same theme that our previous presenter already pointed out, which is they're really not focused on healthcare. But we could be either in a really good position if they continue to ignore us, Or to his point, we could really have a problem if they start to micromanage. So we're going to talk about that. And then I'm going to pull the themes out of what we've been discussing, and I'm going to give you some analogies to kind of help you carry that forward. You know, with my luck, the bill is going to be filed, the draft is going to show up while I'm up here, because this is what happens to me. I was at THIA in 2023, and I was nervous because I had a bill that the governor hadn't signed. So I'm up making the presentation, I'm talking about the bill, I'm like checking my phone frantically, did he sign it, because we were at the deadline. He signed it 10 minutes after I sat down. So it was very rude of Governor Abbott. He should have done that in advance, right, so I could talk about it. So let's start here. Please tell me you know who this is, right? Okay, if you don't, no Schoolhouse Rock. Not now, because now you're supposed to be listening, but later. Go check it out. So this is from a thing called I'm Just a Bill Sitting on Capitol Hill. I was obsessed with this as a child. Some of you who've heard me speak before have heard me say, I was so obsessed, I didn't understand that there was only one version of the cartoon. So there's that point where the bill is sitting on the steps and he's worried about being vetoed because he's going to die if he's vetoed. And baby Nora thought, oh my gosh, that's so awful. Grown-up Nora thought, oh my gosh, those bills are bad and they all need to die. It's okay if they die. Not this little guy, right? We love this little guy. But I grew up, fun fact, Texas legislature last session filed 11,000 bills and 4,000 of them passed. So there's a lot of activity, there's a lot going on, and there's going to be a lot going on in the AI space. So let's start with the lay of the land. We are, 2023 was what we call the 88th session of the legislature. We're moving into the 89th, so it's class of 89. Again, all about me and my Gen X shoulder pads. We are in the legislative interim until January. So the activity from the 88th is continuing, and a lot of what I'm going to talk about is a continuation of activity from the 88th session. Everybody has election day on your calendar, right? And you're all going to vote, right? And you don't need me to remind you, right? Okay, good, moving on. General election is important. I'm going to talk about why that's so in a second. Bill filing begins 6 days after the election. They can start to put bills in the hopper. And for my Laredo folks, the good Senator Judith Zaffarini, her staff person will be at the door with her stack of bills because she is prepared. She is prepared, and she files a bunch of bills on filing day. That's when my social life craters, and nobody sees me again till June. Session will begin in January. Bill filing ends in March, and so a whole bunch of bills get filed that no one will ever see again in the middle of March. And then the session ends in June, unless we have special sessions, which we're not going to have this time, right? Right. I'm doing a lot of praying today. It's generic praying. It's prayers to all faiths. I'm just gonna have that to keep me going. So why is the election cycle important? Well, I want to just spend 1 second talking about this because I think this is critical. Normally, legislators get assigned to committees and they stay on that committee for a while. Maybe they like education, maybe they like transportation, maybe they love public health. We need more of those. We are going to have almost complete turnover of the Republican members of the Public Health Committee from 2023 to 2025, which means we'll have almost no continuity. Several of them lost in Republican primaries to members that were farther to the right. And one of them, Dr. Tom Oliverson from Cyprus, who's an anesthesiologist, has declared himself a candidate for speaker. So just this distinction, if you haven't taken Texas history in the last 30 years, the lieutenant governor presides over the Senate. He's elected by the voters statewide. The Speaker of the House is elected by the House. And then he appoints committees, which are basically rewards for voting for him for Speaker. If you declare for Speaker and you don't win, you're going to end up on the Culture and Tourism Committee and not as the chairman. So we will see what happens with Dr. Oliverson. He may be Speaker, he may not be Speaker, he may align with a Speaker candidate and not be in as much trouble. But my point is, in the House, the committee that we talk about these issues with the most is the Public Health Committee, and most of those folks are going to be new. And that creates challenges for all of us from an education perspective. The Senate's relatively stable, at least in terms of membership. I won't make any other comments. So I'm going to start with wrapping back to what Dr. Jeffrey said about the survey of the state agencies, which has swept up all our academic health science centers. So last session, they passed House Bill 2060, which was setting up an artificial intelligence advisory council with legislators and experts to review activity around AI. This was the first time we had done anything like this, and one of the things the bill said is we want to survey all the state agencies. And I'll give you an example of the kind of thing that they were thinking about. The Texas Workforce Commission has a chatbot. Its name is Larry. It's named after their previous executive director, my friend Larry Temple, who passed away, and it helps answer basic questions about unemployment insurance. That is not the same as the last presentation. It's very important, but it is not the same. So it is hard for me to tell whether they really meant to sweep MD Anderson up in this survey or not. I think they've been a little overwhelmed by the sophistication, by the best practices. If everybody did this stuff the way it was laid out in the last presentation, they would leave us alone. But I'm going to talk here in a little bit about somebody who didn't do it the right way and has already gotten themselves in trouble. So they're doing these surveys. They were due in July. They're supposed to look at state government needs, state government governance, what should state agencies be doing, because we really have these jurisdictional issues where the Food and Drug Administration is going to regulate some stuff, right? HHS federally might regulate some stuff. What is the role of state government? Well, traditionally, it's a couple things. It's state agencies, and it's some consumer protections, and it's occupational licensing, which I'll come back to here in a minute. So they're looking at all this, they're pulling it in, they're going to make some recommendations, and that's going to include things like, do we need a code of ethics for AI adoption in state agencies, which will be a yes, of course we do, that's pretty obvious. But that wasn't enough. Oh no, it's not enough to have the AI Advisory Council. The Speaker appointed a special committee to look at AI in the House, run by the same guy that passed House Bill 2060. So this is Representative Giovanni Capriglione from South Lake. We call him Gio. He knows we call him Gio. I'm not being disrespectful. It will take me forever the number of times his name's going to come up while I'm talking if I have to say his full name every single time. So now you all know that we call him Gio. So the Speaker appointed a committee, charged them with looking at the economic impact, the impact to elections, cybersecurity, all these things. Healthcare, so this is the first time I'm going to say something I'm probably going to say 3 or 4 times and summon sort of either a genie or a demon. I don't really know. Beetlejuice maybe is going to show up. They are not targeting healthcare. They are not singling out healthcare, and they are barely talking about healthcare right now. The top of mind concerns are election fraud, cybersecurity, consumer protection. They're really not focusing on healthcare. So the risk to us is more that they're going to screw up our stuff than it is that they're targeting us and they're going to come after us. Now, the Attorney General just did something that may turn out to say that's not necessarily true, but he's already got tools to address some of these issues. So he just entered into a settlement. This isn't in the slide deck because I think this happened yesterday, with a company that was doing business here in the Metroplex, maybe with some of your hospitals, so you'll have to Google it, who was making promises about their error rate that did not line up with their actual error rate in using generative AI to process patient data. So the Attorney General has nailed them under the Deceptive Trade Practices Act because they were advertising a hallucination rate of like 0.001%. So hallucination, right, we all know this, it's the false data, the made up data, those sorts of things. I'm pretty sure I would have known that wasn't right, just from the get-go. So they put it in their advertising, that's what they told the hospitals. Information then became available that that was maybe not true. So while they haven't pled guilty, they haven't exactly said that they're innocent, they've entered into an agreement to clean up their marketing, do more disclaimers, that sort of thing. So we already have some tools in statute to do this without all this legislative activity, but obviously they feel that that's not sufficient, which is, for some of this stuff, probably a fair observation. So the Select Committee had a hearing. They were appointed in April. They had a hearing in May, so don't ever let anybody tell you they can't move fast when they want to. And they had a bunch of experts get up and talk. So you can, at the end of this presentation, I've linked to everything I'm talking about, so you can go read the reports for yourself. You know what they didn't talk about? Healthcare. You know what they didn't really make any recommendations around? Healthcare. This was, again, elections, cybersecurity, consumer protection, those sorts of things. Oh, we're not done. So as if that's not enough, GEO also held a stakeholder meeting and said, hey, you know, I know we have House Bill 2060 and I know we have the AI Advisory Committee, but I'm putting together a framework to protect consumers. Because that's the thing that he is the most concerned about. He passed a bill last session, House Bill 4, which was a Consumer Data Privacy Act about how long can a website retain your information, how can you get the right to be forgotten from a website, all those sorts of things. So he had a stakeholder meeting. This slide deck that I'm referencing here is not available online, but I'm happy to share it. And he brought everybody together and said, okay, we want Texas to be the global leader in the regulation of artificial intelligence. Really? Okay. I mean, sure, I'm a Texan, I'm all for that. How are we gonna do that? So this was sort of his vision for how that would get done. And I want to highlight a couple things. He pushed out a request for information and stakeholders responded and sort of said, okay, there are things that we're all in agreement on. For example, we don't really want to feed the trial lawyers by creating a private cause of action where private citizens can sue for violation of whatever regulation we create around AI. Everybody kind of agrees on that. Everybody kind of agrees on things like deployers and developers are not the same, right? But what we don't agree on is where the balance is between those things, right? Because what if you're a deployer and you've taken the developer's product and you've tweaked it just a little bit? Where does that balance play out? How do you have third-party certification or do you self-certify to the state that you're compliant? Where is this regulation that he's dreaming of going to live? Well, it's probably going to live at the Attorney General's office, quite frankly. How do you make all these pieces and parts work? So this is an enormous amount of detail. It's sort of summarizing the slides. There is definitely not agreement on a lot of the basic things that need to get done. And again, this is not healthcare specific. This is kind of painting across the whole ecosystem. He's also saying, okay, you know, the AI council's over here and the bill's over here, and so I'm doing the consumer stuff and all of that is great. Some of the stuff that he has listed as unacceptable is really obvious, okay, right? No porn deepfakes. Let's just not do that and let's punish those people while we're at it, please. Some of this stuff feels to me like really obvious. You know what he did not talk about? He talked to us for an hour. He did not talk about healthcare. Again, not one time. Some of that is because the state institutions are being captured in the survey under House Bill 2060, so he doesn't have to do that. But some of it is because he is focused on external consumer risk. And I'll give you an example of the sort of thing he's worried about. He'll say something like, I want to ban anything that exploits human vulnerabilities. Like advertising? Like my vulnerability for Cheetos? Like, what are you talking about? I need more specifics here. What he's really talking about is maybe a chatbot that is not clearly a chatbot. So you think that pretty girl on Yahoo Singles is really a pretty girl. And she's not. She's a bot being run out of Macedonia. Don't do that. We all know not to do that, but people who are lonely, people who are vulnerable, might be more vulnerable to that sort of thing. So I think, to his great credit, he is trying to sort out the different buckets. But without even reading and absorbing 100% of the detail on that screen, can you see how ambitious this is? This is an extraordinarily ambitious layout. Oh, wait, there's more. He's also concerned about what he calls foundational AI. He's concerned about AI that can't pass the Turing test but comes close. How will that be regulated? How will that be disclaimed? How will consumers be told about that? He's worried about robot warehouses that might be completely autonomous. Maybe they get a sandbox to play around with to do their development because they're a closed system as opposed to a consumer-facing system. So you can see some of these distinctions that are getting drawn here. Oh, look at all those other proposals. Holy cow. Isn't that a long list? And I already gave you a long list. Let me tell you the one you should be concerned about as healthcare stakeholders, and it's the first one. Allowing occupational licensing boards to regulate AI. The medical board, the nursing board, so on and so forth. Sounds great in principle. Boy, do I have issues with this one. Now, I'm gonna wait to see the language. But who is not an expert on AI on the medical board? Pretty much almost everybody. Do you want to serve on the medical board, Dr. Jeffrey? Because I could get you on there. They don't have, look at him cringing. They don't have the expertise. They don't. So while I want accountability, what I don't want is anti-competitive frameworks coming out of these boards, maybe inadvertently, because they're trying to protect consumers from harm so much that they stifle innovation. So this is one that I'm really concerned about, that I'm going to be working on, because I have some background in doing legislation around antitrust and occupational licensing stuff. And this is one that makes me nervous, because I think this is a place where well-intentioned people could really mess up our stuff. And I would really prefer that not happen. Oh wait, I'm not done. I'm like Oprah. You get a hearing, and you get a hearing, and everybody gets a hearing. So back to Dr. Oliverson. Dr. Oliverson is currently the chair of House Insurance, and so he held a hearing on artificial intelligence. Rumor has it Geo did not like that very much, because that's his playground. He doesn't want other people on his playground. And they really only had 2 witnesses, and the 2 witnesses sort of talked about, well, you know, different kinds of AI work in different ways, and so you've got to make sure that you make distinctions between the different kinds of AI. Yes, please, thank you very much. So there's some cross current in the House affecting some of these issues that's going to be very interesting once we get a new speaker, or this current speaker is reelected in January. At the back of the presentation, I've actually put a link to this hearing if you want to watch it, because they were the first witnesses. And we're not done. We have the Senate. The senators vacation a lot more than the House members. The House, you can see, is doing all this work. The Senate has had 1 hearing where this has come up, and it was very brief. And they only really had 1 physician speaking to healthcare who was talking about some really important things, like making sure clinicians are in the loop, no matter what level of sophistication your tools are. Again, drawing these distinctions between assistive, augmentative, and kind of more autonomous AI, and maybe they all need to be regulated in different ways. But I think the thing I want you to take away from all of that clutter on all of those slides, that's the worst slide deck I've ever made in my life, this first part. But there isn't any other way to show you what they're up to than to put it in front of you and then sort of pull from it. And the pull from it is they're not talking about healthcare. They're not. They're worried about consumers. They're worried about these other things. So these are the takeaways. Number 1, privacy, privacy, privacy. If they decide to get into the healthcare space, that will be the theme. They're going to be really, really worried about privacy. There is an interest in this topic, but only from a few legislators. So I expect Gio to be reelected. Whether or not he'll be a committee chair with any clout, you know, I don't really know. But they're definitely, they're very interested. I think we're going to see this work around occupational licensure, and I think that's the area that folks should really pay attention to if you're in healthcare. We might have some regulation around the state agencies that may or may not impact the health science centers, but sort of the gossip that I'm getting at the Capitol level is that the health science centers are not the target, right? But we just don't want to be collateral damage. There are some things that they understand that are good for us, the difference between deployment and development, for example, the different levels of AI. Another risk I've identified on this slide that sort of keeps me up at night is they might inadvertently overclassify. This is one that I'm worried about. If all of a sudden the predictive analytics tools that we've been using for years get classified as AI and subject to a bunch of additional regulations, that adds cost and weight to the system with, quite frankly, no benefit necessarily. Now, all of this is not being helped. Dr. Jeffrey mentioned Change Healthcare. You also may be aware that United Healthcare, one of their Medicare Advantage plans, I think, used an AI tool for prior auth that denied care, and it turns out that denial was inappropriate and there were no humans in that loop. If we start to see more of that, the insurance conversation could float up out of the ether and become a conversation that becomes important. But again, you've got levels of regulation. Texas only regulates 17% of the private insurance market. So you have Medicare, which is CMS. You have Medicaid, which is HHSC. You have private insurance regulated by TDI. And then you have what we call the ERISA plans. So these are large multi-state employer plans, and they're regulated by the Department of Labor. And they are the most hands-off regulators that I deal with in the entire sphere of the work that I do. And I'll give you an example of that. During COVID, when we had to do telehealth overnight because COVID, everybody pivoted, but the ERISA plans, they barely pivoted, and they were the first ones to get rid of telemedicine as a benefit. Because their framework is the employer is the purchaser, the employer gets to decide what's in the benefit package. So will they be harder on plans that use AI or maybe get AI wrong? I don't really know. So we're talking about multiple layers of regulation. Another trend that I think is important to note is that GEO and others are acknowledging and integrating existing standards. For example, NIST, so the National Institute of Science and Technology, has a risk assessment framework for the use of AI, so he's not going to build a new one. So can I get a hallelujah? Because we don't need that. So to the extent that we can acknowledge and integrate existing federal frameworks, particularly for healthcare, that is really, really important, because what we don't want is Texas to go left while the federal government's going right, or the federal standards are going right. That you can create some dissonance there, and it can happen really, really fast. So these are some things that I want you to sort of be aware of. And I want to talk bigger picture for a second. So I've sort of blitzed through all this legislative activity. You know, what's really going on? What are they really worried about? What they're really worried about is not us. Even with Change Healthcare, even with this United Healthcare story, we are not the target. However, there are some bigger conversations that I want to spend a couple minutes talking about, because I think they're really important, where what we are doing with AI may become the focus of some legislative conversation. So I want to spend a couple minutes on that, because I want to step away from the bills and the language and the hearings. You can go read them. The resource links are all on the last slide. If you can't sleep, you can go watch the hearings, you can read the bills, you can read the reports. It's all there. And it's actually really interesting, and I would encourage you to dive into some of that stuff. But once you're done, what you're going to do is you're going to be, so what? What does that mean? Where is that taking us? So obviously, GEO has a vision of a single piece of legislation that would cover every one of those tiny little words in that tiny little font that I showed you. I am a little skeptical. And let me be very, very clear. I personally have worked on legislation that was over 1,000 pages long, where I had to be conversant in every page of the 1,000 pages. Not my favorite. Highly don't recommend. 1 star. Not good. Whether there'll be enough consensus, I'll talk about that in a minute, but that's his vision. But that's just his vision. That may not be everybody else's vision. So in previous sessions, when I've had a big telemedicine package, there were 11 or 12 other little telemedicine bills, because a legislator wants their name on it, or their constituents brought them the bill, or they've had an issue in their district that they want to see addressed. So, you know, I understand his ambition to do this. I think the other thing I want to say before I move into the bigger picture is, just because Colorado did it doesn't make it good. And so the question that most legislators were asking of witnesses in all of these hearings, which I avoided successfully, which was amazing, was, well, tell us who's doing this right. Tell us who's got this right. Does the European Union have it right? Was Colorado right? Was California right? And every single witness said no. It is hard to regulate technology that's in motion. And I loved what you said, that this is the slowest it'll ever be. This is the slowest it'll ever be. So how we build a regulatory system to address all of this stuff that's in motion is going to be really tricky. I don't think we have any legislators anymore that don't do email, but for a while we did. So, you know, we've got some techies, and then we've got some other folks, and they're all going to come together in January, and we'll see what they do. But part of what's going to happen is a bigger picture conversation around healthcare, and I want to spend a couple minutes on this because I think this is just incredibly important. We all know we have workforce shortages, right? Where are my nursing folks, nursing programs, nursing faculty? I love you so much I can't even begin to articulate it because I know my long-term care days are coming, so I need you to save me. I need you to make sure we have enough nurses. And look, again, I'm Gen X, I'm real simple. Saturday morning cartoons, bowl of cereal, leave me alone, I'll be good. I don't think I ask for much. But we all know about the workforce shortage, right? Another statistic I'll share with you, because this is the one that blew my doors off. Acadian is one of the big ambulance companies out of Louisiana. They're in Austin, they're in other places. The average age of a paramedic, according to the association that they're a part of in West Texas, average 65. I just want you to sit on that for just a second. I have been in the legislature for 30 years. When Butch Oberhoff from Acadian dropped that number in Senate Finance, I have never seen a room go cold like that room went cold. This is what we're dealing with. So, first of all, we've got a workforce shortage. Second of all, do we fully fund Medicaid in this state? We don't. Imagine that. So that adds to the problem because we're not even paying Medicaid providers really to cover their cost. On top of that, you have a very robust fight about scope of practice and whether or not we should be making changes around advanced nurse practitioners and other professions. It's an ongoing conversation. Only a third of our physicians take Medicaid right now. But I also heard some testimony recently that most of our advanced nurse practitioners are in the cities and in the urban areas and not in the rural areas. And that may be because they can't prescribe, so they can't really fully do the function. So that comes around to artificial intelligence. Because if I have, okay, those of you who are meeting me for the first time today, I'm funny, right? I'm fun. I have a sense of humor about this. Those of you who know me know that I am petty and mean when people are misbehaving. I am perfectly capable of believing that way. If one more Silicon Valley 20-year-old tells me that we are going to magically make the workforce shortage disappear because of his app, I am going to lose my mind, and Susan and Marion and Mary are going to have to bail me out of jail. The way that we incorporate artificial intelligence into workflow, and again, Dr. Jaffray, you could not have set me up better. The people processes are the center. People are not going to go away. We are not going to not need nurses at the bedside. What they do might be different. Hopefully they'll be helped and assisted instead of having, I've seen so many bad deployments where tech tools are docked on top of existing workflow and then the vendor does this. And what happens? What happens? Clinical staff are unhappy, doesn't do what the patients need it to do. Artificial intelligence is just a tool. It's an amazing tool. I've already seen some amazing stuff, and I have to tell you, listening to you talk, I'm a cancer patient. So the future of what could happen for me because of the work that MD Anderson and UT Southwestern and all of our partner institutions are doing is pretty incredible stuff. So please continue to make me a priority. I would appreciate that while I'm eating my cereal and watching my cartoons. I don't think I ask for much, but we are not going to AI our way out of our workforce shortage. That is not a thing, but that's a thing that people are claiming is possible. Now, can we get better tools? Can we cut down on administrative clutter? Can we finally get rid of fax machines? I don't think I'm asking for very much. I think we could have a 5% improvement in productivity right off the top if we just got rid of the fax machines. But apparently the lawyers aren't willing to get rid of them because they think they're more secure. I had a nurse say to me once, the only way you know if your paper record is secure is if somebody's dusted it for fingerprints. So there you go. But see how all of this comes around? Like increasing Medicaid rates would help with the provider shortage. Doesn't solve it, but it would help. Correct deployment of artificial intelligence will alleviate some of the burdens on our providers. That is real, right? So if we put a heavy level of regulation on how hospitals deploy AI, am I able to use it to help my workforce? No, because I'm going to come out on the losing side of that equation. So while there does need to be some regulation, it needs to be regulation that empowers, and that is possible. You can do that instead of regulation that is a big list of things you're not allowed to do and a bunch of compliance that doesn't really matter, to where people are going to throw up their hands and not be interested. You do have to have good governance. You have to have all that stuff in place. And again, I think our opening keynote really drove that home in some ways that are really important. And then scope of practice, maybe we get to the point where the supervising physician for the nurse practitioner is AI assisted or AI augmented. We're really going to be moving into these virtual spaces in some really interesting ways. One of the ones that I'm completely obsessed with is the use of haptic sensors in virtual reality, so that you would be wearing a device where you could feel the physical therapist moving your arm for your physical therapy, like you're on the holodeck in Star Trek. This is real stuff happening right now. The assisted augmented audio, where we can maybe let our physicians go back to something that looks more like dictation. How many resources are we spending right now on things like scribes for people's EHRs? All my doctors have scribes now. That's a cost. That's a weight. And I am a fan of what EHRs can do, but come on, really? Like, there's better uses for those people if they have an interest in being in healthcare than scribing into an EHR. So we'll get there. So this is the way I want you to think about this as a policy conversation. There is the top-line discussion of AI. What is AI? How do we regulate? How do we classify? All that stuff. But in health policy terms, AI is part of a much larger conversation, and that is one of the takeaways I want everybody to have today, is that it's really, really important to see how these pieces intersect and interlock, and how we can hopefully put a really positive face forward for the way that we're using AI in our healthcare institutions, and then be like, oh, by the way, could you just fund a little more Medicaid, just give them a little bit more money? That'd be good. I also want to say, some of you who've heard me talk at THIA or at HIMSS Regional, I talked a lot about property tax reform, being very concerned the legislature will want to spend all the money on property tax reform. Well, Senate Finance just got the first set of numbers from the Legislative Budget Board. Guess what the price tag is to eliminate property taxes in Texas? We have it now for the first time. School-based property taxes, completely gone for a 2-year cycle. Yeah, I know, I'm seeing some faces. $84 billion. The entire general revenue budget for the last 2-year cycle was $144 billion. So no, we do not have $84 billion in the couch cushions or the rainy day fund or any other location. So it's going to be interesting to see how they pivot away from property tax reform. The other thing I want to say, and here we're kind of getting into the wrap-up, my undergraduate degree is in government, because of course University of Texas at Austin calls it government instead of political science, like every other university on the planet. And in my degree plan, I had to take 3 classes in a science. I had to pick kind of a mini major in a science, and I picked astronomy, because my dad worked at Rockwell, and Rockwell built the space shuttles. So I was sort of obsessed with all of that stuff. So there's a phenomenon that happens called planetary alignment, where you're able to see a whole set of the planets and they all kind of make a little, faux line across the sky. We just had one. I think we'll have another one later this year. It's fairly unusual, but we're in a season where there's a lot of planetary alignment. Why is she talking about this? It's a fair question. In order for the legislature to pass an artificial intelligence bill in 2025, it will have to look like that. You will have to have the business community assessing that it's not going to put people out of business, that compliance isn't going to be too burdensome. You're going to have the consumer groups agreeing that they're getting the sort of protections that they think that consumers need. For example, if you're interacting with an AI chatbot, for a loan application, for example, that process is going to become completely automated. There aren't going to be any humans, and particularly for our underserved communities, they're not always treated very fairly by those algorithms. So the legislature is going to want to see a way to appeal to a human. This stuff could all line up. How much is it going to cost to regulate artificial intelligence at the Attorney General's office? Is that 2 people? Is that 10 people? Is that 20 people? The House of Representatives, you might remember, impeached the Attorney General last session. And most of those members are coming back. So are they really going to want to grant big, broad, new powers to a man they impeached? Now, you have to look at it as the function, right? But all politics is personal when we get into session. So all of this stuff, again, will have to line up. Businesses will have to be comfortable. Frankly, MD Anderson would have to be comfortable. If the team from MD Anderson comes to me and says, we've got a problem, I'm gonna listen. And the good news is the legislature takes that very, very seriously. Our academic health science centers in Texas do not lobby, ever. They answer questions. They do not lobby, but what they do is educate, and they do an outstanding job, and they are a trusted resource, thank goodness, to the legislature, and I sort of expect that to continue, because where is the expertise on AI right now? It was on the stage before me. It's people like Dr. Jeffrey, your whole team, all of that work that's being done is light years ahead of what anybody in the legislature knows about this stuff. So having healthcare, even though they're not talking about us, we have a seat at the table, and that seat's really important. We've got to treat it like the precious opportunity it is and tell them to back off and leave us alone, for the most part. Unless you're doing consumer-facing stuff, in which I think there's going to be some good work to be done there. So planetary alignment is what we're looking for. It's more common than you think, but it doesn't happen every day. And that is sort of how I feel about an omnibus artificial intelligence regulation bill at this stage in the game. It's not in my email, I just checked, so we still don't have a bill draft. But for those of you that are in my partner institutions, you'll be hearing from me about it. There are lots of ways for you to be involved and engaged, and this is sort of where I want to wrap. Keep in mind we're in a general election cycle. In Texas, the presidential winner doesn't always have coattails. So don't assume just because somebody's ahead in the polls, either way, in the presidential race, that's going to have some impacts down ballot. The makeup of the legislature, particularly the House, because again, the Senate's not going to move around, will dictate the temperature. And we could be looking at everything from a Cold War to a hot mess. I don't really know. Or something in between. I would settle for like just a warm bath, you know, something kind of in the middle. I'm like Goldilocks, not too hot, not too cold, need this to be just right. Pay attention, though, to the interim hearings and the press releases and the interim reports if this is of interest to you. Lots of little nuggets there. If you read it, absorb it, think about it, you'll start to see the trends. That's basically what I do for a living. You can do it too. And the last thing I want to say, because I get this question a lot, there may be some philosophical differences about regulation, but the need to, quote unquote, do something about AI is very much bipartisan, which means it may have a better chance, even if we have a stressful partisan session, of being an issue everyone can coalesce around, because I think everybody is concerned, particularly, again, about consumers, about something going wrong, and they're going to want to do something about it. So I think I've stopped at a good point to open. I wanted to leave a few minutes for questions, and then here at the back of the slides, I have hyperlinked to everything I just talked about. And I know they're going to distribute the slides, so then you can just grab those hyperlinks if you want to read the AI Advisory Committee report or listen to either of those hearings and hear the testimony. If you've never done it, I highly recommend doing it at least once so you can understand how human these people are. Because the legislature in Texas, for those of you that have never heard me say this, you all know, I know y'all know, how much do they get paid a year? Come on. $7,000. So to your point, you got to spend to get, and we spend $7,000 a year. And I think I'm just going to leave that there and see if anybody has any questions. Thank you very much for your time. That was a lot. Oh, also, I should say, this is the first time I've done this speech in front of an audience. I put this together for you. So this is breaking news, brand new, no one else has seen it. And I appreciate, I watch your faces while I'm talking, so that really does help me sort of figure out where I need to go. So again, I love and appreciate the faculty that invited me to be here, and I'm happy to take a question or two if anyone has a question. And no questions about the legislature are dumb questions, because they're the legislature. They are not an HRO. They are not. Yes, sir.
I do have a question. I heard on the news yesterday that Governor Greg Abbott appointed a brand new business court, and according to the news, it's like over 100 years major court reform. I know it's not from the legislative perspective, but do you see this type of reform having a positive effect?
So I haven't read it. It's in my inbox. So can I just kind of speak generally to what the governor does, or are you looking for me to dig into that topic? Because I only saw the headline, so I didn't read the whole thing. I haven't read the whole thing yet. Either way. Okay, so the role of the executive branch is kind of this is an interesting question because you have to remember who Greg Abbott is. Greg Abbott was Attorney General. Greg Abbott tends to lean into the courts are a good place to take things. Law enforcement is a good place to take things. At the same time, he's also inherited a decade plus of Texas winning the Best State to Do Business award. So without having read the announcement, all I can really say is he's got to balance the dynamic tension of the fact that he's a lawyer and he likes regulation with the fact that he's supposed to be leading the most pro-business state in the country. And that is a tricky balance for him, and sometimes he tilts, but what really tends to happen is they tend to be, I'm trying to find the word. He tries to find a balance between those things, and so the things they do are not always terribly effective because they've been so vetted. Does that make sense? Okay, yeah, sorry, I wish I read that email. I have not, sorry. He broke news. This is what we're doing today. Breaking news. So I'll have to dig some more into that after I'm done. But I hope I at least answered a little bit of your question. Yes, ma'am.
Hi, I'm Mary Teets. I teach health informatics, so I try to keep the students up to date. I'm also a nurse, as you could tell earlier, and we are seeing AI affecting us every day, as we talked about the various ways that it's infiltrating our healthcare delivery system. So I have two comments here. You might remember in 2000, I think you were around then too, 2009 when we went to electronic health records, everybody was going to get either a carrot or a stick for going with their EHRs, and we were supposed to have HIEs. Right? That was what we were supposed to do with all the electronic health records, is connect them all. Is this the initiative that we're trying to still do? That's one question. The other question is, how do we relate to other states? In terms of, are other states struggling like we are, or are they further along the way?
What a great question. Let me start with the easier part of it first. So the HITECH Act in 2009 did have incentives for electronic health records and health information exchange. Pretty much all of our hospitals, except behavioral health, except long-term care, have EHRs. So we didn't fund incentives for very large parts of the delivery system. So we don't have parity across the system in terms of access to those electronic systems. And if you were to look at Medicaid spending, it's inpatient hospital and it's long-term care. That's the spend. That's where the money goes. So we didn't lift up some of the, to be fair, harder parts of the system, and so those providers are really struggling, and we're actually looking at some stuff for this session to push some money in the direction of the providers that did not get included in the HITECH Act. The second part of it is the health information exchange piece. We did not incentivize that properly, in my opinion. We gave grants and people did planning and they stood up institutions, and some of them, Houston's has been very successful. Dallas-Fort Worth doesn't have one. Not in the same way that Houston has one. There's a number of things that have impacted that. Epic is one of them, because a lot of Epic hospitals say to me, why do I want to pay anybody else? I already have to pay Epic. And that's not a slam on Epic, that's their public position. So I'm quoting somebody, just for compliance purposes. That was a quote, not my opinion. So I think that's complicated things. And then on top of that, you have 21st Century Cures implementation, which took forever, because 21st Century Cures passed in 2016, and we just got information blocking finalized, last year? So if you're not familiar with information blocking, it sort of turns HIPAA on its head, and it says if you get a request to share data, you better share it unless you meet one of these exceptions. And that is not how HIPAA functioned, right? Everybody has hidden behind HIPAA for decades and not shared data. Now you can actually get in trouble if you don't share data. That ought to incentivize exchange. What I will say about Texas compared to other states is all the big states struggle. There is a land war in Asia in California. There's a land war in Asia. Oh, let me tell the joke before I talk about the land war in Asia. Please tell me you've all seen The Princess Bride. Okay, so Nora's rules. Number 1, never get involved in a land war in Asia. That's from The Princess Bride. Number 2, never argue with a Sicilian when death is on the line. Also from The Princess Bride. Number 3, never get into a fight about HIEs when they're talking about them as nouns instead of verbs. Because that is the most territorial group of people I have ever dealt with. They're like those lost tribes of the Amazon. They've never met any other people, and they sort of poke you with sticks if you come too close. They're supposed to be sharing data, and they don't necessarily, for hosts of reasons. They might inside their region, but not across, which is what THIA, under 21st Century Cures, the Trusted Exchange. See, everybody hates THIA. Somebody's shouting it down from the hallway. In the 21st Century Cures Act, we also had THIA, which is the Trusted Exchange Framework and Common Agreement, supposed to facilitate the pieces of HIE that didn't get done with high tech, and it's voluntary. So you don't have to do it. So all the big states are struggling. There's some very successful HIEs where their state government's gotten very involved, but it is tough. And I know we're at time, but I'll say this. Had Congress and CMS pushed value-based care along with high tech on a parallel track where there is shared risk and shared interest across institutions for patients, we would have had a much stronger both policy and financial incentive for exchange. That did not happen. We are still struggling, right? I mean, everybody here knows we do value-based care, right? No, we don't. We do fancy fee-for-service. Fancy like my jacket. We're not there yet. And the IT systems and the infrastructure and all of that has to be where it needs to be for that to work. And given that we left out behavioral health and we left out long-term care, we have an uneven ecosystem to build all that stuff around. So that was a great question, and the answer is it's complicated. Any other questions? I know I'm at time. Okay, thank you all again for your time and attention and for laughing at my jokes.
So we're going to move into a coffee break, but we just want to make a quick reminder from the registration desk. If you did not register your car for parking, come see us at the registration desk. We'll give you a QR code. Make sure you don't get a ticket. If you do get a ticket, still come see us. We'll take care of it. We also have a raffle going, so if you did not get your raffle ticket when you walked in this morning, please, again, see us at the registration desk. And we'll be back here for the panel at 10:45. So enjoy your break, visit the posters and the exhibitors. Now that I'm seeing you in the seat, I know, you pointed it out.
I was happy
hiding behind. The physicians always know, they always know.
Hiding. Darn, that was our spot.
This is really good.
If y'all don't mind, can I take y'all's photo? Sure. I think y'all are all good right there.
Three, two, one.
Thank y'all so much.
If everyone could please take their seats, we are ready to begin.
Good morning, everyone.
Good morning.
Glad to see all the smiling faces. This is a beautiful facility, my first time here, but this is a great building. I'm admiring it, and then I was just told it's going to be renovated soon and be even better soon, so that's fantastic. Good morning, everyone. My name is David Gibbs, and I am at Texas State University, one of the members of the Texas Health Informatics Alliance that's sponsoring this event, and it's my privilege to introduce the panelists for this morning's panel. The title of the panel, Augmented Intelligence in Healthcare Insights from the Information C-Suite. So the first panelist is Teresa Meadows, Senior Vice President and CIO at Cook Children's Healthcare System, where she leads over 350 team members in driving digital transformation across the integrated pediatric healthcare organization. With over 20 years of experience, including roles in nursing and healthcare consulting, She has been instrumental in modernizing clinical systems and improving cybersecurity. Dr. Velasco is Chief Health Information. Has a fan club, preferred parking. Dr. Velasco is Chief Health Information Officer at Texas Health, where he oversees clinical decision support, medical informatics, and the implementation of electronic health records, leading the organization to receive the Enterprise Davies Award for Excellence in 2013 and achieving HIMSS MRAM Stage 7. He is a fellow of HIMSS and an inaugural member of Modern Healthcare's Top 25 Clinical Informaticists. Dr. Siraj is Senior Vice President and Chief Health Informatics Officer at Harris Health System, which is the fourth largest safety net health system in the United States. In his role, he leads the informatics and data science strategy and operations for the health system. Dr. Siraj is passionate about leveraging information technology, data, and human relationships to provide patient care that has high quality and reliability, and has been doing this since 2001. And then finally, our moderator is Dr. Bassett, Associate Professor in the Department of Internal Medicine at UT Southwestern Medical Center, specializing in cardiology with a focus on risk optimization. As the Associate Chief Medical Informatics Officer and Associate Director for the Clinical Informatics Center, Dr. Bassett conducts research on machine learning and for clinical decision support. Please welcome our panelists. Dr. Bassett.
Dr. Gibbs, thank you so very much. And for the conference organization, thank you so much for putting on such a wonderful event and inviting all of us up here to speak. We're so grateful for this opportunity, and we look forward to this discussion. Dr. Velasco, I'll start with you. In this last few years, large language models have really transformed the problems that we can solve and have accelerated what we're able to do. It's been remarkable how quickly the platform's changed. You recently gave a wonderful presentation on leveraging LLMs in the EHR environment. From your experience, what problems do you feel that they will help us solve in the near term, and where do you feel the hype is for the conference?
Thanks, Dr. Bassett. And also, thank you, organizers of this great conference, for including me on the panel. As a preface to the answer to Dr. Bassett's question, I'd like to share a framework or concept, really, that I'd like to share with you. It's the notion of the jagged frontier of AI. Have folks heard of that term, the jagged frontier? I don't know if it was coined by, but it's certainly been popularized by Professor at Wharton named Ethan Mollick. So if there's one thing that you might take away from my comments on today's panel, you might want to check him out. He wrote a book called Co-Intelligence. It's a very easy read, very fun to read, actually. And I think a good introduction or really discussion about the evolution of AI in society, in the world. And I bring that up because I think it's a good way of thinking about your question, Dr. Bassett. You know, when ChatGPT first came out, it was amazing what it could do. It's like, you know, generated quite a bit of excitement. It seemed like it could do anything, answer a lot of questions. But as we've tried to apply that technology in different settings, use cases, we are amazed at what it can do, but as well, we are sometimes shocked at how badly it falters at something. And that's the jagged frontier of AI, where you know, in some cases it excels, but in an adjacent application of that same technology, not significantly different, it falls quite short. And I think the implication of that is really the need for experimentation. It's being very bold and applying use cases of AI in different areas so that you get to explore and probe the jagged frontier of AI. So that's my kind of introductory comment. Actually, in the lightning rounds this morning, Dr. Rodriguez-Fernandez, I think his name, from UTMB, gave a really nice coverage of some of the early uses of generative AI at Texas Health. So I would just refer you to his data and what he shared earlier, because they're, I think, very illustrative. We've really seen very similar patterns at THR. I tend to think of AI not as applications so much as use cases. What is the AI doing, or what is the functionality creating? What is the workflow that it is impacting? So in the case of the examples that we talked about this morning, the draft response, which was one of the first use cases that got a lot of attention to the patient message, medical advice request through the portal. I think a lot of opportunity. Definitely, we've seen a lot of issues with patients misusing that way to communicate with their physicians. And so I think the technology does offer some promise in responding to and helping to alleviate some of that burden. What we've seen is about a 20-30% adoption, similar to what was presented earlier. But what's interesting is that it is not a it's very uneven. There's some physicians that use 50-60% of the draft responses and some that don't use any of it. So there's a lot of variation is that what we're seeing in there. And I think it gets to the point that Dr. Jaffrey said in his comments. When the AI is only responding to the PMAR as opposed to the full context of the patient's history, then it's going to give a potentially limited response. So that's just one comment there. Another use case that we've applied that we found very good success is with clinical summarization. So that's another AI use case where I think AI offers a lot of promise, taking vast amount of information in the medical record, kind of making sense of all that note bloat, and really providing a very nice synthesis of what's going on with the patient that can then lend itself very easily to a discharge summary, the hospital course, nicely summarized. So those are two that we've seen a lot of good early success. The third that I'll comment, again, Dr. Rodriguez Fernandez mentioned this as well, ambient AI. And that has really been quite revolutionary. It has undone the disruption that the electronic health record has actually introduced into the patient-clinician encounter. So whereas before the advent of electronic health records, clinicians, physicians, nurses were interacting face-to-face with the patient. And with the advent of clinical documentation in the electronic health record, now the clinicians are on a keyboard facing a computer screen instead of the patient. Ambient AI has allowed the clinicians to restore that human-centered aspect of the clinical interaction, and that has really been very positive from a patient, a physician satisfaction standpoint. And just last week, we actually got our first data back from Signal, showing an improvement in documentation time, decreased off-hours documentation by the clinicians that have transitioned to ambient AI. The one interesting data point, which was kind of paradoxical, was closing charts the day of the encounter. That actually went the opposite direction. And I wonder if it's because physicians are now so accustomed to not interacting with Epic in real time that they're forgetting to close the record after they're finished with their ambient AI-enabled clinical encounter.
That is so fascinating. I would not have expected a reduction in that, but I think you probably are getting to the dictation part of it, right? That you're coming back to edit it later. Dr. Suraj, I'll ask you, you're uniquely positioned in a county hospital system which serves a unique population. How do you balance AI for populations that may be under-resourced and underrepresented in healthcare data, but still provide the value that some of these systems create?
Yes. Our patients are unique in that they don't have all of the resources available to them. We currently have about a 65% uninsured rate for the patient population we manage. So the way that AI can really help is to streamline the use of those resources that we have. We're always at capacity. And the supply of patients always exceeds the capacity that we can provide. So that's where I think AI can really help streamline those capacities. Let's think about the patient workflows, right? How does a patient decide that they're going to either go to a doctor, a clinic, or go to the ER? Using AI, preferably some type of a chatbot functionality that's also available in multiple languages. because that's something we see in our patient population as well. The majority of them are Hispanic speaking. We have Vietnamese, we have Hindi and Arabic. That's probably the majority of our patients. So if you have an AI chatbot that can seamlessly converse with patients to help them navigate the system to ensure they go to the right place, we don't want all of our patients showing up in the ER. Inadvertently, that's where they end up. But how do you move them around? I think that's where AI could really be leveraged. We're not there yet. We are working on, I would say, upgrading all of our foundational systems where we can incorporate that functionality. And then the other challenge, I'll go to the tail end of the workflow, which is after the patients receive the medical care, how do you ensure appropriate follow-up? Again, we never have enough resources to pick up the phone, call those patients, converse in their language of preference, and be able to give them appropriate advice so that they're taking all of the necessary follow-up care, getting their prescriptions filled. So leveraging, again, some type of AI chatbot or even conversational AI to encourage patients. I read in a recent study that the in-basket responses that were being generated, they were more empathetic than the actual humans. So I'm confident that we can get more engagement from our patients. And then finally, what I would say is that the biggest use of AI for us and for our patient population is continuing that engagement process when they're not under the care of our hospital staff or our clinic staff. How do we keep them out of our healthcare system, outside of our four walls? Because again, capacity is a huge problem for us. So tools for patient engagement, promoting healthy lifestyles, nudges to, hey, have you drank enough water? Have you had your share of fruits and vegetables? We often find that our patients are probably I would say the biggest use cases for social determinants of health. So again, a Big Mac is much cheaper than healthy fruits and vegetables. So how do you encourage them, but also create those systems that allow them? So at Harris Health, we actually have a food pharmacy. Pharmacy is spelled with an F, F-A-R. So we essentially give these qualified patients 40 pounds of fruits, vegetables, healthy foods every week when we enroll them, so that they get accustomed to eating healthy and seeing the change in their health, so that becomes a motivator for them to continue that behavior. That program usually lasts about 8 to 12 weeks, and then we do connect those patients with appropriate community-based resources so they can continue on that. So it's a mixture of AI. I kept hearing the word, what was it? AI, what was the term that was just, it's not meant to replace, but it's supposed to augment. Yes, there we go, augment. AI augmented healthcare. That's what it looks like for our patient population.
That's really amazing. I love the food pharmacy idea. That is such a great idea. Mrs. Meadows, you are uniquely positioned, especially on the pediatric side, and dealing with children's data is very sensitive. How do you manage that for AI solutions for high value, high reliability, quality systems?
Yeah, that's a great question, and thank you for allowing a nurse to be on the panel with all the physicians, so I appreciate that.
And Yolanda, she got the hard question.
I did get the hard question. I don't know how that happened exactly. You know, in pediatrics, it's really a unique environment because most of the AI solutions today have been created towards the adult populations. And it's primarily because the software companies who create these algorithms, there's more volume in adult facilities than there is in pediatric facilities. And they also make a lot of assumptions that children are just little adults and that, you know, any algorithm can work just based on the data that you have, and it's definitely not the case. And so some unique things about pediatrics, if you're not familiar, is a lot of the things that happen in kids happen in age-based ranges. So vital signs when you're an infant versus vital signs when you're 12 or 13, the normal vital signs are very different depending on the age of the child. So when you have an algorithm that uses vital signs, if they're based on adult-based norms, they're going to produce errors in children. The other thing that's unique about children is there is the family dynamic. So when you start looking at SDOH, a lot of things where algorithms are like the in-basket messages. The in-basket messages were designed to respond to the patient. In pediatrics, we want the in-basket message to respond to the parent or the caregiver. So the algorithm is not smart enough to know that Teresa is the mother and Lucy is the child. So the in-basket message will say, hello, Lucy, like she's the mother, or like she's the patient. Yes, she is, but she's not the person who I'm trying to respond to. So we've done a lot of work working on these algorithms to help the algorithm understand who in the medical record is the right person to communicate with. And another easy example in pediatrics, you have lots of other people who could be caregivers. It might be the father, it might be the grandmother, it might be CPS. The mother it might be an adopted situation. And so the algorithms today still are not smart enough to learn those variations in the caregiver population that's taking care of that child. And so there's a lot of work that has to still occur there. So I think we're probably several steps back as far as AI is concerned in pediatrics, but it is catching up quickly. And the way we catch up is participating, because that's really been, I think maybe people's concern is we don't want to participate. Let's let the adult people figure that out. Well, if we don't participate, then we're already behind the 8 ball as far as getting the technology developed where we need to be. So we've been early adopters in some of the technology, especially with our EHR vendor, to really help them learn how to address some of the issues around pediatric dosing and medications, pediatric vital signs components, even behavioral health. There are specific things around behavioral health that are related to pediatrics. And then looking at those proxy relationships about who, if I'm going to generate an automatic response, who should I be communicating with, and does it make sense to be communicating that way? So there's still a lot of work to do, but those are the kind of the evaluations we do. And what we'll see from our standpoint is we'll partner with a lot of early startup vendors to help them determine and build those pediatric use cases, because we want to solve problems. We don't want to buy technology. And so if we can work with somebody who wants to solve a particular problem, then we'll be early adopters to that platform or that particular software company to help them develop that process.
Hey, Dr. Bassett, I wonder if we might ask Teresa to touch on our hallway conversation, because I think it's an interesting use case, the maternal vaccination challenge. Do you want to speak to that?
Sure. One of the things that we've been actually working with our colleagues here is, as many of you may know, there was a vaccine created in the last year for RSV. RSV is a respiratory illness that in children, specifically 0 to 2, can be life-threatening and potentially even cause death. And so as mothers in their 3rd trimester begin to get the RSV vaccine, those antibodies are then passed to the child once the child is born. A lot of times those children, sometimes when they're born, end up having to go to extended intensive care called a NICU. And we receive patients from THR a lot, where the mom gave birth and then the patient needs to come over to our NICU for some additional care. One of the things that would be very beneficial to clinical care is to know if the mother received the RSV vaccine as part of her pre-pregnancy care. The way the technology works is, because the mother is not our patient, we don't have access to her vaccination record, and the only way to get the information is for us to ask the mother. And then if we ask the mother, there's nowhere in the medical record for it to go, because the mother is not a patient in our medical record. They are in the family history, but not in the medical record. And so we've been working very closely with our EHR vendor to say, how can we build an information exchange that allows us to get these critical data elements like the mother's vaccine record to our care. So, because we might change the way we actually treat that child if we know the mother had a vaccine, And maybe we can also do extended research on that as well, because I think there's going to be a lot to learn over time about how those vaccines actually impact longer-term care on children and others. In his organization, if the child stays there, they have the whole record. They have the mom, they have the baby, they have everything. So it's easier for him to look at that holistically, where we struggle with that. So we've been working on the technology component to say, how can we share that easier than what we do today? I don't know if you'd add anything to that.
I'll ask one more question, and then we'll open it up to the audience if you guys have any questions that you... Dr. Strauss, I'll come back to you, and I'd like the rest of the panel to answer this question. Being at a county institution, you probably have the highest level of scrutiny here, because you have so many government bodies that analyze what you do. In terms of AI, how do you build governance that's robust enough to withstand that scrutiny?
Yeah, is this being televised? I'm just kidding. Yeah, we're definitely under the microscope more often than other organizations because we're a county resource. From an AI perspective, how do we govern it? It's important to recognize that AI implementation in any healthcare institution requires governance. And it also stems from the fact that all of the data that gets fed into the AI models also needs to be governed. I've read that almost 3/4 of all healthcare institutions, they're not ready for AI because their data is not ready for AI. So as a county organization, we do have a data governance committee. It's in its very, I would say, early stages of maturity, but once we have that data governed, we can go ahead and implement AI. We rely heavily on vendors. Because we're a public healthcare system, we don't have a whole lot of resources. We can't go out and build out our own AI. We just can't. It's not feasible. So we rely on our vendors. The vendors will really help us get there. But having a good understanding of how that data is being used by those vendors to generate whatever it is, whether it's advice or whether it's clinical protocols or whether it's clinical decision support, it's important for us to understand how those models were trained. And we have data scientists on our team who can do that. We have to translate much of that algorithm work into plain language so that everyone can understand. But we've also created a subcommittee that's focused just on AI governance as well. They're interconnected to the data governance, and we have all of our executive leadership team on the AI governance along with our IT and informatics partners. But it's really about transparency and visibility into the models. Oftentimes, because of intellectual reasons, vendors don't share how their algorithms work, and I think that is a problem, especially when it comes to AI governance. And for us, as a safety net public healthcare system where our patient population is unique, again, oftentimes these vendors will come with models that haven't been trained on a more robust data set. And the way to overcome that is to educate these vendors who don't quite understand the complexities of patient populations, whether it's based on race, ethnicity, socioeconomic status, geographic location. Those are all contributors of health status. And it's up to us as healthcare leaders to educate and maybe have those arrangements with these vendors early on. I think Teresa talked about startup vendors. If we can get a front seat on, hey, let's help you develop the most robust model, that's one way that we can make it more robust. And yeah, the scrutiny for us, I think in healthcare in general, there's always a lot of scrutiny. But those are some ways that we can overcome it that we've already implemented, but we can continue to work on.
Yeah, well said. We were joking about that earlier. You know, I think, just to add to that, I think sometimes it's assessing the level of risk. So in our AI governance and our data governance structure, we have a risk model where we assess, okay, how much risk would this be? So there are a lot of safe bets or safer bets in AI, especially with large partners like your EHR vendor or your ERP vendor, because they're building at scale and they have the resources to build at scale. So they may be less risky to do some of your initial AI exploration with. So being an early adopter to in-basket message responses is safer than maybe going with a startup vendor who doesn't want to share their algorithm, and really looking at where the data is, how the data will be stored, the dreaded cybersecurity components about how will the data be used, getting some of those core risk elements. So we built a risk assessment that we do to determine how risky something is. Especially, there are a lot of things in AI that would benefit healthcare that don't impact direct clinical care. There are lots of administrative things that we can do that will improve workflows, functionality, improve our billing, that are pretty low risk. And it allows you to put your toe in the water and learn how to look at an algorithm and how to assess, can an algorithm be successful or not. And then you can graduate to more complex things like clinical interventions. So I know everybody goes immediately to the clinical side, but there are 1,001 uses for artificial intelligence on the administrative side that healthcare should tap into, because those are the things that are going to keep us viable from a financial standpoint. And so when you're thinking about your governance, don't rule out maybe testing the waters with something less clinical, because that gets people more comfortable with moving towards the more complicated things.
So ironically, our system AI task force is meeting right now. So I'm missing the meeting, but this was more important. So I elected to be here with you all and learn. I echo what Teresa and Suraj have mentioned. The only thing that I would add, and I would really endorse what Teresa mentioned about really applying AI outside of the clinical domain, because that's less risky. I think there's a lot of opportunity. There's huge administrative documentation burden that doesn't involve patients, and it's really ripe. It's low-hanging fruit, really, to leverage AI capabilities to harness those functions. Dr. Jaffrey mentioned this notion of platforms. And yes, there are a lot of startups, there are a lot of kind of niche players in various things, but it's important for those AI capabilities to be integrated with those core systems that you use, whether it's for clinical care, revenue cycle management, policy development. And so it's somehow that AI, if you're going to use it, has to be integrated with those platforms. So that concept resonated with me from his keynote this morning. And then, yeah, I think those are the main things. I think we're going to, although the clinical stuff is really exciting and very attractive, because there's a lot of drivers for that, I think that what our governance is going to be very focused on over the next couple of years is the value realization. How do we measure the benefits, financially, ideally, of investing in the AI? And I suspect that many of the non-clinical use cases, so accelerating revenue cycle management, dealing with denials, prior authorization, some of those things that are kind of behind the scenes, but can really make a huge impact in terms of your bottom line, are where I think AI will have a lot of promise.
I'll just add a little bit to that. And if anybody has any questions, if they want to come up to the microphone, I think this would be a perfect opportunity. Is when we look at the healthcare enterprise, we already use algorithms to solve key problems. And we've never been in a scenario where we scrutinize those algorithms. I don't think anybody cares which algorithm is being used in your EKG system to do your initial interpretation. And there probably are failures in those systems. AI is just a more sophisticated form of those algorithms, and I think that's really ripe for innovation. If you look at Nest, when the company came out, fundamentally what they did was they said, why do we have these old antiquated thermostats that nobody has innovated on for 20 years probably? Like I think they still use mercury thermometers in those. So they created this innovation for these antiquated algorithms that people fundamentally forgot about. And I think healthcare really is ripe for that. And I think that's where the clinical domain will really come in. And I completely agree with the panel. The administrative side of it is really ripe. It is allowing us to do the things that we as clinicians have really valued doing, that patient interaction, and taking away the burdensome administrative interactions that the early versions of the EHRs did. One of the things that they did was they task shifted a lot of that from administrative staff to clinical staff, and that was the vast majority of the cost savings that these EHR vendors advertised. And now we're shifting all of those back to hopefully AI solutions that probably will do it far better than I ever could. I'll open it up. Any questions that people would like? Dr. Chur?
No tough questions.
Oh, it's probably going to be tough. So one of the things I love about this conference is that it squishes together C-suite members like yourselves and students from, I think we heard from somebody who's getting their bachelor's degree. You know, we've got our fellowship level trainees, our master's level trainees, and it puts them together much more than some of the big national conferences or industry-driven conferences. And I think we've all experienced operationally the disconnect between what y'all are talking about right now and either the very heavily based research programs that give methodologic rigor and training and the applied side that kind of does, but you know, you get the same 2 lectures on an ROC curve. How do the educators in the room create the folks that y'all want to hire to do this work? What is needed in our workforce to accomplish this?
Well, I would love to take that one. When I graduated from my master's program in health informatics at UT Health, by the way, I'm wearing the socks for my UT Health friends. That was the exact struggle I had. And I've been in conversations with a lot of the faculty at the school to help them understand, and they're really good at it because they listen. I have the opportunity to intern a lot of students from the school, and I find that there is that gap. I think with more, I believe, with more hands-on experiences while the students are in the program, I think that's where you'll really get the benefit because those students are smart as heck. They're the ones who can help connect the dots between what they're learning and what it is we're doing. So I think more of those practicum-based courses will be beneficial. The healthcare is just fraught with thousands and thousands of data opportunities. So educating those students on not the theoretical aspects of data, but the practical aspects of the data. So when they see a data set, they shouldn't focus on, oh, let me build something cool like a ROC, right? But rather understand each of those variables are columns. How does that translate to the front-end workflows? What are the key decision points that are being made by those clinicians? And what that does is it allows the students to add more context to the data so they can actually ask the right questions to answer with the data. I think that's a huge gap right now. I have plenty of ideas. Again, a shameless plug. If there are people who want to work with me, I'm more than happy to provide those real-world use cases so that we can build a better curriculum for our students and then prepare them to join the workforce. And as soon as they join the workforce, they're really hitting the ground running. So that's my take on it.
Yeah, I may just add a couple of comments. As much as I hate to admit this, I got my master's in informatics a long time ago from the University of Alabama at Birmingham. And when Marita Johns created that program, she did a really smart thing, which is interview people in the job. And she interviewed, I don't know how many CIOs, lots, and she created a curriculum based on the feedback at that point in time in history. And I think that's part of what's missing between academics and the real world is hearing from the people who do it every day because it can craft a curriculum. And she built in some of those practicum things very similar to what you suggested because I do think it's seeing how the work happens, understanding the workflow, understanding why, because a lot of times people who build tools, they don't understand why we do things the way we do them, and the why is super important. And when I look for people, for my team, I look for people who are inquisitive, who ask a lot of questions, who aren't scared to try things and maybe possibly fail. How I ended up in IT, I don't know, because I said yes to something and I had no idea what I was saying yes to. And so sometimes taking on a task that you may not be 100% comfortable with is super important, and understanding the why we do the things we do. Is it the right reason? Probably not sometimes. We might do it because the law says we have to, or, this is the way a physician likes to practice or a nurse likes to practice. But at least if you understand that, you can build that into your thought process of how you might design something better in the future. So understanding workflow, understanding data, and understanding it in real context, because the context is super important, would be things that I would encourage people to build into their programs.
I don't have much more to add, except maybe to kind of flip the question around to the faculty here. We were talking about this at the break, and one of the challenges that I've been kind of nagging the task force to deal with is the uneven AI literacy of our workforce. I mean, there are some that are very sophisticated that are using these tools in their everyday life, planning their vacations, and so they get it. But then there are some that aren't even using it at all. They don't understand it, they're fearful of it. And I think that's a huge opportunity. And I guess the question is, what is the role for academia, for professors at the universities to help those of us in healthcare organizations to address this gap?
I see what you did there. You just did a reverse panel.
Yeah, I like
Nice.
Yeah. I think it's a really important skill to learn how to solve problems, because if you look at the technology that we used 10 years ago to solve these EHR-based problems, it is completely unrecognizable to what we do today. And, a couple of years ago when I got my undergrad in computer science at Baylor, I was fortunate enough to go to a language agnostic program. So we take a class and said, welcome to numerical methods. Oh, by the way, you have to do all your solutions in Fortran. I know nobody uses it anymore. It'll tell you how dated that is. And we spent one class learning how to do Fortran, and everything else was about the theory. And I still apply the theory today, although I do it in vastly different languages. So I'm optimistic that 10 years from now, we will use vastly superior systems and architectures that don't exist today and probably hopefully not even imagined today. And so learning how to solve problems, regardless of the platform that you do it in, is really important. And for the young learners out there who are really interested in, build a portfolio of something that you've solved and have an understanding of the process that it was solved within, so you can articulate that during an interview, is really important. And you will continue to do that throughout your years. So learn how to learn and stay up to date on what current platforms and technologies are currently available. We continue to do that all the time, and that's really what's very exciting about this field. Is I think that gives you job security because it keeps you current, and it keeps us excited about the new problems that we can solve tomorrow that we might not be able to solve today.
Okay. I love what y'all just said, being a faculty. I teach health informatics. That I had my question, but I'm going to actually ask if all the students in the room could, if you're shy, you can raise your hand, but if you could just stand up or raise your hand so we can see how many are here. How many students? Okay, look at this. This is the beginning of what look at this, okay? This is, and thanks for standing up. You're hired. Oh, there's another stand up, okay. And I hope the students in my courses are here because I'm like, they're saying what I say all the time. So this is all good. We're in the process of filling the pipeline for what we need to do. So, but faculty, someone was talking about an EMT being 65 years old, the average, okay? That's where we're coming along with that. And there's a lot. Okay, where's the faculty? How many faculty do we have? Stand up, stand up. You guys can stand up. Look at this. Look at this. Look at all the faculty. Yay, 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 yay. Okay, from all over. So this conference is really helping the movement. So here's the question I want to ask, and it started out with you, Ms. Meadows, where you talked about the struggle with algorithms for children. We struggle in clinical, particularly when we're teaching, because we try to teach binary, caring for the binary patient, for the transgender patients and so forth. We have trouble with the lab values. And what do we have available for the normal range, okay, of lab values for someone who is transgender or binary, and that's my patient today. And sometimes it's not there in the lab. Can each of you just kind of touch on where we are with that in terms of your clinical systems, if you do have that available? It's usually for the hematocrit, RBC, those kind of values that differ for males or females, but there's nothing for the in-between.
Great question, thank you. We haven't solved that, but we're working towards it. And I think maybe what I can provide is the process rather than the solution, I think is more important. And so it was a similar kind of issue, actually, where a patient who was transgender was prescribed a medication that is contraindicated in pregnancy. The patient self-identified as a male. And so that was how the patient was seen in the electronic health record, and therefore there was not a question, are you pregnant? Or could you be pregnant? This medication shouldn't be prescribed without even a pregnancy test. So that actually sensitized us to the need that you described here. And it's been a process. I think we're, Joni, like a year into it now. And so we started with behavioral health because it was a behavioral health medication. And it starts with the cultural aspect first, the awareness, the need for an understanding of the issues that you're talking about. Forget the technology, right? Don't start there. That was actually where they were going. We need a BPA, right? And I'm like, wait a minute.
I was just going to recommend that for you.
Okay. How can we even have a BPA if we don't have the data to correctly identify the patient's possibility biologically of being pregnant? So we've gone through that process now. We're about to introduce the same capability. So there was a lot of scripting that we had to develop for our patient access staff to collect more comprehensive SOGI information so that we can now use that information. Now, we haven't thought down all the way to the point of what does that do with reference ranges and things like that, but at least now we have the potential for biological sex to complement the self-expressed gender.
Yeah, I was going to add, that's exactly what we're doing right now is foundational. I don't believe there's a solution out there, but the fact that you're asking the question has ignited some thoughts and ideas which I think are foundational. So the first piece is, are we collecting data on gender identity, right? That's the first question you have to ask yourself. We started about 6 months ago in our organization. But remember, it's not a simple, hey, here's the multiple options for gender identity now, go ahead and check a box, right? Because for the staff who are interfacing with the patients, it's a box that they have to check. But how do you ensure that they're checking the right box? And that's where what Ferdy just talked about is that cultural transformation with our patient access staff, our nursing staff who are interfacing with the patients, so we're getting the right data. Now, if everyone started doing that, and we had this, I would say, tsunami of data now, that will enable us to identify what those normal parameters are. And then we can use that new learning to start to drive all of the clinical research associated with the question that you just asked. And then, of course, the Ferdy's question, if we have that data that's valid 100% of the time or as close to 100% of the time, and you have somebody who has identified as a male, you could use that information to prevent those kinds of events from happening, right? I think building a BPA is your, I would say, your trigger function of, hey, we'll just build a BPA, but if you don't fix the foundational data problem, those BPAs are going to be inaccurate and they're going to fire all the time. We have Dean here who has studied alert fatigue. Dean Siddig, are you in the house? Where are you? Okay, I think he's hiding outside. But alert fatigue is real, so foundational data is the way to go. And oftentimes it's, not oftentimes, most of the times, to collect good data is a challenge in healthcare. It really is, so.
Yeah, I might just add one last comment. Don't underestimate the amount of education that people need to collect this data. So if most of our patient access personnel, those are entry-level positions, they turn over a lot, they are not trained to have sensitive conversations, and they are not going to probe to get the right answer. So if you start there, nurses even aren't really trained to ask those types of sensitive questions either. And so as you start looking, most of this is an educational process, and that's where we have spent 90% of our time. The technical process is like 1% of the equation, but you cannot underestimate the data collection piece and the understanding and people feeling okay asking the sensitive questions. I mean, SOGI information is scary. People don't even want to ask if you have a food insecurity, much less how do you identify. And so those are the types of things where we're spending a lot of time getting people comfortable that it's okay to ask the question, do you have a hard time finding food? Or do you identify a certain way? Or, you're being abused. I mean, there's a lot, and it's all in the education. The EHR is not going to solve that problem because we're always going to be collecting data from the people. What could help is allowing people to enter their own data into the EHR, so allowing patients and families to enter their own data so that you don't have to be asked, and they are more honest with the computer than they are a human sitting in front of them. So ways that we can capture data ahead of time, allowing them to enter their own information will make the data better long term.
Yeah, that was part of our strategy as well, is sending out reminders through MyChart to the patients ahead of their appointments so that we collect that data. Yeah, good point.
Yeah. I'd like to answer the question slightly differently. I think volume of data will really help answer this question. Because one of the holy grails in medicine has always been personalized medicine. And I think what really excites me of AI and EHRs in general is as we aggregate larger systems of data, we're able to answer these questions for smaller and smaller subpopulations. Like, Teresa mentioned this, is that we subdivide pediatric patients into decades, right? And the reason we do that is for convenience. There's actually no technical reason for doing it. It's easy for us as human beings to understand decades. And we do this quite frequently. Like, why is CHADS? It's because someone built a giant model with 30 elements in it, and nobody could remember it back in the day. And we simplified it as small as possible and made it into 5 elements because people can remember that. And then what's the history of that? We realized that's inadequate, right? It severely underperformed. So then we created CHADS-VASC. Now we're in the era that we don't need these acronym-based solutions for our feeble clinical minds. Now we can use the fully... That's very true. Dr. Velasco can handle 40 elements without any issue. Right? But now we're at the time and the stage where we have enough data that we can have these more complicated, more accurate models providing more personalized care and therefore more accurate thresholds. And I think that'll change. And I'm really optimistic that we will move away from absolute value-based guidelines. And we'll have truly personalized guidelines that'll say, like as a cardiologist, I still to this day do not understand why someone whose baseline blood pressure started out at 90 is treated the same as someone whose baseline blood pressure is 120. We're delaying treatment for these people quite significantly, and now we're getting to the volume of data to be able to answer these questions, and that's what's really exciting.
The key takeaway I took from that is I'm in the 5th decade of my pediatric age. That's what I took from it. I like it. I like that definition.
I have a question related to this sort of data topic. So this is Literacy Month, actually. How have programs on data literacy within your organization? Given it's so important, I'm curious, are all of your employees learning about data, how to manage it? Because we've gone from a world where informatics has, I guess, thrown this anyway, survived on the digital exhaust of the practice of healthcare, and now we're moving to a time where we need to help get on that first mile and collect the best stuff. So I'm curious about your programs on engagement around data literacy.
Yeah, we're actually in the very early stages of building a data literacy program as part of our data governance, because what we are finding is people do not understand the core data that they're looking at. And they don't understand the definition, and because healthcare has various definitions, how do we educate people on the definition so that they're using it appropriately when they're looking at a data set and saying, okay, that's giving me the answer I expected it to answer. So it's kind of my pet project I have going on where I'm trying to build a program to help clinicians and business and executive folks, when they look at a metric, understand how that metric was calculated, what data was actually used, and what was the definition of it. People always use the length of stay definition because it's the easiest one, but there's 75 ways you could define it. And depending on how I'm interpreting it in my head, I may say that data's right or that data's wrong. And so how do we create a data catalog with your analytics and your data that says, when you see data that looks like this is how it's defined. When you see it how it looks like this is how it's defined. And then training people for the data that they use in their daily activities, not on the whole ocean because they'll go nuts trying to boil the ocean there, and how they use it in the context of their daily work, because the context is always missing, always. And that's the part we're trying to figure out with informatics is how do we get data in context with definitions so people understand it, and how do we train people on how to use it?
I couldn't agree more with Mrs. Meadows on this. It's first of all, having available data, having access to data is where you start that journey. So anybody who has access to our Epic system has access to Slicer Dicer, so they can do the analysis. But what we've noticed, and I think Dr. Chu is in the room who leads our education program, so I definitely talked to her about it. And she's done a really amazing job introducing people to analytics on what you do with informatics solutions. But there's a limit to it, right? Data science is a profession for a reason. There's a reason why we teach PhDs on how to do this. It is complicated. And at a certain point, you have to decide as a researcher, do I want to climb that steep learning curve to understand ontologies, to understand these complex workflows and these complex architectures of these data systems that we have? Or do we allow a system so that you can partner with somebody who already has these skill set and that can be worked more efficiently? So at UT Southwestern, we've provided both routes to people. You can get a basic understanding of it, take more advanced courses on it, or partner with people in the Clinical Informatics Center to help you do that collaborative research.
I do have a question here, over here.
Could I really quickly answer that question? Data literacy program, the answer is no. But do we want one? Absolutely yes. So, yeah. Yeah, go ahead.
Okay. I'm an engineer, but I'm not necessarily an early adopter of technology, so I don't use Copilot or ChatGPT. Last year at a symposium, I heard from Dr. Bruce Tromberg, the director of NIBIB, and he's an amazing guy, and he is a big fan of AI in medical imaging. And I'm surprised to hear that FDA has already approved a lot of different algorithms, but that's from the FDA approval. How it translates into a clinical setting is what I would like to hear you guys' thoughts on. And I always have the impression that the radiology faculties and practitioners are pushing back on all this, new algorithms and new ways of reading images. That's just my impression, but I would like to hear what you guys think of that.
So I think the gist of the question is clinicians or radiologists in particular are pushing back against the algorithm. And at our institution, I think the exact opposite is true. They want to make their jobs more efficient. We're at that, the fear is there that AI is going to come for their jobs. And I don't think that's going to happen in the near future because of one really important thing is licensure. You have to have a radiologist read the report in order to be able to bill for it. And when that changes, and I think they will push back against that, then we have a totally different scenario right now. Right now, they're measured, especially if you look in the commercial domain of radiologists, they get paid by the number of studies they read on a given day. If you increase and provide technology to increase the number of studies they can get paid on a day, they love you for it. It's the exact opposite. So they are embracers of technology. Now, a lot of the AI solutions that we see in that domain are not very good. And I think that's the part that they probably push back against.
Yeah, the only real comment I have here is algorithmic bias. So there's two aspects of bias in algorithms. One is, was there some flaw in the data or the way that the algorithm was developed that introduces the bias? What I'm actually talking about is over-relying on algorithms. That's what I mean by algorithmic bias. And I think there's a danger in this, this pursuit of efficiency or whatever, trusting the predictive models or the AI-based algorithms to be correct because it's coming out of a computer. So I think there's a real danger there, and I think that's something that we need to, as healthcare providers, be very conscious of, and that needs to be part of our literacy efforts, is don't trust the algorithms. You need to use your clinical professional judgment, cross-check. That's why there's a human in the loop, to your point about licensure. And yeah, if the system is saying the patient's not at risk, but you think the patient is, don't let the score reassure you in a false way.
Yeah, the only thing I would add is marketing drives fear. And so the marketing of these tools, the number one marketing thing is, we can do the job for you. And if the marketers were smart, they would say, this is how I'm going to help you solve an issue. You still have to be involved in the process. And so I think there's a big gap between how products get sold or try to be sold, which breeds fear in not just clinicians, in revenue cycle personnel who say, we're going to implement AI and we're not going to need 10 revenue cycle people, we're only going to need one, right? And so it's all in, a lot of it's in the delivery and how we present the solution to the problem we're trying to fix. And it should not be, we're presenting this solution so we can replace you. We're presenting this solution so we can help reduce burnout. We know that the number of people going into radiology is dwindling. The number of physicians who want to go that route is dwindling. We want you to stay happy and enjoy doing the role that you're in. And the way we support you is providing you technology that can support your clinical decision-making, not take over your clinical decision-making. So a lot of the hype is what is scaring people not to want to use the tools. And we have to figure out how to get the hype out of the message and how we direct it towards, here's the problem, here's how this will help you be more successful in the role that you're in. Will we need less people? Yes, but that wouldn't be the message that I would start with. That would be the message that I might end with at the end of the day when we prove out, is that right or wrong?
Yeah, I was just going to say, if I have another 20-year-old startup vendor come and tell me that they would solve such and such problem for us and our organization, I'll be right there with Nora.
You got to do the pose with it. So, there you go. Very good. That was a wonderful question, 4 wonderful answers. Thank you to our panel. We had a great panel discussion. I've got a few instructions before we take our lunch. Lunch is in this room. It's available on the edge over there. There are some birds of a feather table. If any of you are looking to find other folks with similar interests, down front, we have a research working group table, policy and standards table, education and workforce development right down front, and the data working group over on this side. So if you're looking for some folks, come down front and find your flock.
Can we go to more than one table?
Yes, you can
okay,
move
good,
around.
Good. I was conflicted
chairs
there
are
for a
portable.
second. Okay.
Very good. Also, the poster and exhibitor sessions will start at 12:30. Posters are on this side, and then we will resume for the workshop session at 1 o'clock. Thank you.